quite soft-spoken, but quite powerful. She reminds me of the story when Sir Winston Churchill, as Prime Minister, stood in the corridor with his assistant, and he said, the assistant said to him, Sir Winston, there goes a modest man. And he said, he has much to be modest about. Stacy has much to be proud about, but she's very modest. Welcome, Stacy.
Good morning, everyone. Thank you for being here with us. I am tasked with the privilege and the pleasure of welcoming our keynote speaker, Dr. Zahi Toma. And it's the second time he's here on this stage with us. In 2019, he was also our keynote speaker. So indeed, this is an honor for him to be back with us, though virtually, sharing his expertise with us. Dr. Zahi Toma is an associate professor of medicine, clinician scientist with the University of Toronto, and scientist with the Schroeder Arthritis Institute and Krembil Research Institute. He's a staff rheumatologist with the University Health Network, where he serves as director of the Lupus program. He is also an adjunct scientist with the Institute of Work and Health. His research is focused on systemic lupus and measurement science, with a particular interest in the assessment of disease activity, patient-reported outcomes, and cognitive function. Dr. Toma has established the Neuro-Lupus program with the goal of developing improved methods of identifying cognitive impairment in systemic lupus, understanding its course over time, and its impact on health-related quality of life and productivity. Dr. Toma is also co-chair of the Criteria Subcommittee of the Quality of Care Committee of the American College of Rheumatology for the development of classification and response criteria for rheumatic diseases. He's also the coordinator, co-instructor of the Measurement in Clinical Research course at the Institute of Health Policy, Management, and Evaluation at the University of Toronto. Dr. Toma is a co-chair of the SLE Outcome Measures in Rheumatology Working Group, aiming to update the core domain set in systemic lupus. He sits on the advisory board of the Lupus Ontario and the Lupus Foundation of America. He has been appointed as the inaugural Dr. Murray Horowitz Chair in Lupus Research. Today, he will speak to us on neuropsychiatric lupus, current concepts, and management. Help me welcome this esteemed speaker, Dr. Zahi Toma.
Good morning. Can you hear me well? Okay. Thank you for the invitation. It's a pleasure again to be with you, and as you said, this time virtually, but hopefully many years in the future, I will see you again in person. I want to share the slide. Just give me a second, please. Okay. Can you hear me well and see my slide?
Yes.
Yes. This isn't okay. Okay. I don't get any message, but probably I presume you can hear me. Okay, so let's start.
Yes.
So this is my disclosure. And those are the learning objectives for today. I would like to go over the 19 neuropsychiatric syndrome in general, understand the critical step in differentiating primary disease-related and secondary disease-unrelated neuropsychiatric syndrome, and share with you some update on the research that we have at the Toronto Neuro-Lupus program. And I will start with my first objective. So as we know, lupus affects many organs, and my today's presentation will be primarily focused on neuropsychiatric lupus. To set the stage, neuropsychiatric lupus, as you know, is one of the most complex and challenging features of systemic lupus. It's very diverse, and the American College of Rheumatology has described 19 syndromes. We cluster them into central and peripheral. Each of these syndromes has one or more underlying related pathological mechanisms, and often they do overlap. Now, in addition, there is a clinical overlap with different neurological and psychiatric disorders, which makes the neuropsychiatric diagnosis and attribution to lupus often challenging. Like any manifestation in lupus, we do have activity, remission, and subclinical state of the disease when it comes to neuropsychiatric lupus. And attribution is key, and we'll spend some time talking about this throughout the presentation today. Neuropsychiatric syndrome in general, as you can see, the prevalence goes all the way from 14 up to 75. And really this depends on how we're defining neuropsychiatric syndrome. 6 to 28% of these syndromes in general, they do occur within the first year of the diagnosis of lupus. But we know that we continue to cumulatively accrue more neuropsychiatric events over time. But we have to remember that the attribution to lupus disease activity does not remarkably change over time. It actually remains stable. Now, regardless of the attribution, we know that neuropsychiatric events are associated with decrease in quality of life and significant organ damage. Some facts. At this level, we continue to have lack of clinical appropriate tools to guide us in the diagnosis for neuropsychiatric syndromes. Lack of diagnostic biomarkers, and when I say biomarkers, this could be an imaging biomarker, a lab biomarker. We do have as well lack of trial focus on neuropsychiatric lupus, and over the last decade, we haven't seen a significant change or novel therapy, I want to say, when it comes to neuropsychiatric lupus. Now, going back to the classification, as you can see here, we can have two groups. The central nervous group, which includes 12 of these syndromes, and peripheral. And itself, the central could be diffuse and focal. Under diffuse, I've highlighted one of the most common one: cognitive dysfunction, mood disorder, anxiety, and you see psychosis as well. And I'm going to share with you one of the cases today around psychosis. Under focal, you've got cerebrovascular disease, seizure, aseptic meningitis, movement disorders, myelopathy, and demyelinating disease syndrome. And under peripheral, you can see as well a number of these syndromes. In this table, I highlighted again the frequency when it comes to the prevalence. And again, cognitive dysfunction, it goes all the way from 6.6 to 80%. And as I highlighted earlier, this high variability really relates on how each of us is defining cognitive dysfunction. Are we using a standardized tool? Are we relying on patient-reported outcome or PROM? Or is it driven by the assessment of the healthcare provider? Anyhow, mood disorders comes the second, anxiety, headache, and so on. And psychosis, it's between 0.6 and 11%. And I will get back to psychosis later on. So you're seeing this patient, 19-year-old woman with lupus, which was diagnosed in 2020. She initially presented with malar rash, subacute cutaneous lupus, confirmed on biopsy, as well as discoid lupus, serositis, positive ANA, anti-dsDNA antibodies, anti-Rho, RMP, La, Smith, ribosomal P antibodies as well were positive. Antiphospholipid antibodies are negative, and she did have low C3. She did initially receive, when she was diagnosed with lupus for the above listed manifestation, prednisone 30 milligrams a day, which was shortly tapered over 4 weeks. She was initiated on Celcept, but the patient stopped this 3 weeks later on after she developed arthritis, and she was worried if the Celcept MMF is behind the development of arthritis. She's on Plaquenil as well, adequate dose, And subsequently, after stopping MMF, she was put on AZA, 150 milligrams a day, but there was an issues regarding adherence to medication. And as you can see here, she did have different lesions, including over on the skin, including patchy alopecia, subacute and cutaneous lupus, and discoid as well. Now, in January of 2021, she had a second hospital admission with visual and auditory hallucinations. She did have periods of agitation as well as low-grade fever, but sometimes reaching up to 39. Lab tests showed leukopenia, lymphopenia, slightly elevated CK. The rest of the lab tests in terms of chemistry were unremarkable. There was no evidence of proteinuria on the urine analysis. The LP was done and it showed mildly elevated WBCs and protein as well, but no, the workup for infection was negative. Further imaging, particularly brain MRI, did show non-specific areas of white matter hyperintensity to signal in different locations. She did have mild volume loss and some linear areas of enhancement. So in conclusion, the radiologists interpret this as likely inflammatory disease with the presence of small vessels vasculitis. So in light of the clinical picture that we have here and the lab and imaging test, and particularly after we ruled out metabolic disorders, infection, we end up with a diagnosis here of lupus psychosis, and we attributed this to lupus activity. So she was initiated on prednisone, AZA was continued, and very importantly, we need to mention that she did receive antipsychotic medication. And this is very important when we treat lupus, neuropsychiatric lupus, because as you know, it takes time for prednisone to kick in, sometimes 4 to 6 weeks. So very important to treat the syndrome appropriately with the medication that are needed. In this case, it was risperidone. Then later on, she was transferred to our hospital because of persistence of her symptoms. She did receive small pulses of 500 milligrams methylpred over 3 days and continued after that on prednisone 50 milligrams, and the medication for antipsychotic management were optimized. By week 3 to 4, she did have improvement of her symptoms. So if we look at the trajectory here, it took us really between both hospitals anywhere between 4 to 6 weeks. And as I said earlier, it takes time for these symptoms to improve. So don't panic. Sometimes if you don't see right away improvement, just stick with the treatment that you have decided on and optimize the dose of antipsychotic medication. So I'm gonna move on now to talk about how can we get better in terms of attribution. Now, I'm gonna start talking about something different than neuropsychiatric lupus. I'm just giving here an example of the skin. And if we look here at the state of the disease, we can see that we have subclinical in yellow, which often we don't know about it, but probably if you do a biopsy, you might find something. And active, which is when the patient presents and if you find on the exam hair loss, alopecia, or skin rashes, inflammatory, and they go on into remission. I want to say that at this level, we can clearly delineate between scarring lesion and active lesion when it comes to the skin. And we're able to relate this to lupus activity or not, and differentiate whether this are we dealing with if it's over the face rosacea or other manifestations that are not directly related to lupus activity. But if you agree with me, when it comes to the brain, it's more challenging. There is no doubt there is something going at the level of subclinical, and we often see on the MRI demyelinating lesions and other findings that we clinically cannot interpret at this level. An active manifestation like the patient I described right now with picture of psychosis. And often you use medication and the disease itself goes into remission. But it's very challenging when it comes to the attribution to lupus and the neuropsychiatric manifestation. Now, going back to the patient that I present earlier, just to give you a follow-up, after 4 weeks from being in hospital, she was discharged. She did have significant improvement, and the dose of prednisone was already been tapered very slowly and carefully. She was able in June 2021 to drop her prednisone down to 15 milligrams a day, and this was resulted in recurrence of her symptoms. So prednisone was increased again to 40 milligrams a day, and AZA at that time was substituted by MMF. And we had to escalate as well the antipsychotic therapy. She did achieve finally remission of the psychosis in 2021. In 2023, she did have recurrence of the skin lesions despite being on appropriate dose of Plaquenil and MMF, and she was adherent to her medication. She did have as well findings of skin vasculitis, dsDNA improved but still positive, the complements were normal. And this flare occurred when we dropped the prednisone to 7.5. So the plan was moving forward to initiate one of the biologic. And at that time, we went on and initiated Benlysta. And she's doing belimumab. And at this level, she's doing very well. And she's in remission in terms of skin, neuropsychiatric manifestation, and normalization of the dsDNA antibodies. So I'm gonna shift gear now and take you to the attribution. And there have been a number of models, starting by the SLIC, SLIC is the international group of researchers and scientists focused on lupus research. And I'm gonna talk today more about the Italian attribution algorithm. So why do we need attribution, and how can we define this? Bottom line, what we're doing here, it's a process that will establish whether a clinical picture you're seeing is really related, the neuropsychiatric event, is related to underlying disease. And particularly here, I'm talking about lupus. And if it is, we do call it primary neuropsychiatric lupus. And if it's not, it could be secondary neuropsychiatric lupus. Now, to arrive there, we need to rule out many things. Subsequently, being a lupus patient doesn't prevent the patient from experiencing what other patient and individual can have, such as metabolic manifestation that could cause any of the neuropsychiatric manifestation. It's a mimicker of lupus neuropsychiatric syndromes, such as hypertension, diabetes, uremia. You need to rule out adverse event to therapy, infection, and unrelated event to lupus. And once you've done this, you can get closer to talk about primary neuropsychiatric lupus. Now, when we look at the Italian attribution models, there are 5 main pillars that I'm gonna list here, or rules. The first one being the interval between the onset of the neuropsychiatric lupus in terms of the diagnosis of SLE. So as you can see here on the bar, the closer you are to the diagnosis, the closer you see the neuropsychiatric syndrome, close to the diagnosis of SLE, the higher likelihood that what you're seeing is really related to lupus activity. And the further you go from the diagnosis of lupus, less likely. The second rule is the presence of concurrent non-SLE factors. So if you don't have any of these factors, then probably what you're seeing is related to lupus activity. And the more you have of these factors, it could be unlikely related to lupus activity. And I'm gonna give you examples later on. The frequency of what we call neuropsychiatric event in the general population, which means anxiety, depression, headaches, those syndromes often are not attributed directly to lupus activity because they're very prevalent in the general population. And the last rules is favoring factors. So if you look at this model, the Italian model, each of the syndromes that I highlighted earlier, they provide you with a favoring factor that increase the likelihood and give you a more weight score that what you're seeing is really related to active neuropsychiatric lupus. So let's deep dive more into this, how it works. So remember the first one, we set the time to the event. So if this is happening before the lupus event, you won't get any score. If it's happening within 6 months for diagnosis of lupus, you get 3 points, and after 2 points. And remember here, You add all these scores, it's a cumulative score, and the higher the score, the more likelihood that you have a neuropsychiatric lupus event related to lupus. The second pillar was the presence of the neuropsychiatric event as defined by Anila, or the prevalent neuropsychiatric event. Mood disorder, anxiety, lupus, headache. If they're present, you won't get any point. And if they're absent, you get 3 points. Confounding factors, if you have any of these factors, you won't get, but if you don't have, you get more points, which is such presence of diabetes, hypertension, uremia. These are confounding factors that could explain the neuropsychiatric event. And we have what we call favoring factors, such as, I'm going to give an example. When you have psychosis, the presence of ribosomal P, it will give you, it's a favoring factor, it will give you a point. If you have lupus activity at the same time, that's also a favoring point. And again, if you want to go into the details, the paper that I have highlighted below provide you with all these favoring factor and confounding factors. So when you do all of this and you get to the score, anything greater than 7, it will increase the likelihood that the neuropsychiatric event that you're seeing is really attributed to lupus activity. And if it's less than 3, it's unlikely. And you can see this graphic, it gives you the sensitivity and specificity. So remember, we said we need greater than 7. And if you have greater than 7, your sensitivity will be around 60 and specificity 90%. And if you bring it down to 6, your sensitivity and specificity will be 75. So you can see how you can change the trade between sensitivity and specificity depends on the cutoff you have. And the further you go down here, you will get more specific in terms of attribution to lupus activity. Let's go back to the patient, if you remember, that we talked about earlier, and try to score it together. So she presented with psychosis occurring within 6 months for diagnosis of lupus. So if you agree with me, you get here 3 points. She did not have minor neuropsychiatric event, so she will get as well 3 points here. She did not have confounding factors as well. She wasn't exposed yet to the large dose of steroid and no history of previous major stress. So that also gives you a 2 point. She did have favorable associated factor, ribosomal P positivity. The lupus was very active with rashes, fever, and positive serology. So the fact that you have 2 factors, it will give you 2 points as well. So if we sum all of this together, 3, 3, 2, and 2, and 2, bottom line, we end up with 10. And if you go back to this graphic, let's see where we are. So remember, those are the points we talked about before, the cutoff 6 and 8, but our patient did have 10. So you're really high on the curve here, and that's your specificity. So what you're seeing at this level, you're confident that this is 97% specificity, that it is really related to a neuropsychiatric event. So this is, again, one of the models that you can use in your clinic that can help you and guide you in terms of attribution. And back to our picture here, at this level, we gathered information that this is related to lupus activity, and you will treat the patient appropriately. I will get to the therapy later on. I want to stop and talk a little bit about pathogenesis. And this is beautifully described by Dr. John Henley and his team in many papers over years. So this can be divided into 2 groups, ischemic and inflammatory. But really, in real life, they do overlap, okay? And it's hard to delineate. And you're going to see, depends on which pathway you think the neuropsychiatric syndrome is attributed or related. This kind of, in a way, dictate your treatment and the treatment and management. So what do we understand by ischemic pathway? What are the mediator there? They're usually antiphospholipid antibodies, immune complex, and complement system activation, which leads to different mechanisms, particularly vascular thrombosis, micro and macro, complement activation, and angiopathy. And often, those are related to focal neuropsychiatric events such as stroke, while the inflammatory pathway involves different antibodies, cytokines, and analytes, which leads such as NR2, ribosomal P, and in terms of cytokines and MMP9, S100 beta, and others. And all this leads to activation of microglia. It leads as well to a leak in the BBB permeability. And this often is related to what we call diffuse neuropsychiatric manifestation, such as psychosis. But you have to keep in mind that lupus patients are not exempted from having as well complications that are related to lupus: hypertension, uremia, complication related to therapy, corticosteroid infection, and concomitant concurrent non-SLE neuropsychiatric diseases. So you can see here the complexity and attribution. Now this slide is very busy, and I'm not gonna go over everything, just to highlight the different things that as well are implicated in the pathogenesis. Starting with genetic, we talked about the BBB, or the blood-brain barrier dysfunction, the role of antibodies, complements, cytokines, analytes, and don't forget atherosclerosis. We know that lupus patients do have accelerated atherosclerosis. So this by itself is a risk factor as well. Now, a few words about psychosis, and this is related to the group of SLIC, and this paper was described by Dr. Hanley et al. So they analyzed at that time the data in SLIC, which is around 1,800 patients, mean age 35, and they found 31 psychotic events, which bring the prevalence to 1.5. And often the patient did experience one single event of neuropsychosis throughout the disease span. And psychosis in these patients was often attributed more than 80% to lupus activity. And it occurred early on, up to 3 years after the diagnosis of lupus. And it's significantly associated with impairment of quality of life, but the psychosis itself, it resolves after a year, and it's associated as well with improvement in quality of life. Now, what they found as well, that often there is a positive association, in particular, I'm talking here about psychosis, with prior neuropsychiatric event, male sex, younger age at diagnosis, African ancestry, the descendant, presence of antiribosomal P antibodies, but this did not really discriminate between patient with and without MPSLE. And as I said earlier, we don't really have good biomarkers yet, even when it comes to antibodies. What do we know about investigation and what we can do? And I'm going to divide this into two major groups. Neuroanatomical imaging, which I showed you earlier, an example. So it guides you and gives you information about structural and volumetric findings on the brain. Other modalities could be used, such as diffusion tensor, MRI, but those are still more into the research and hasn't made it yet to daily clinical practice. As well as we've learned over a lot of years, and again, this is a lot of work led by Dr. Hanley and his team, around the blood BBB, or blood-brain barrier imaging, particularly with the use of DCE MRI contrast, and other modality is cerebral perfusion. Now, also in the research field, we learned about we're learning more and more about the utility of PET and resting and task-based functional MRI. What do we know about treatment? 3 major steps to achieve an accurate diagnosis, I want to say. And I'm saying again diagnosis because really, once you achieve this and you've done the attribution model, I think that the treatment will flow a little bit easier at this level. So you need to exclude infection, metabolic disorder, malignancy, and adverse event to medication. You need to select what is accessible at your center. We talked about the measurement of antibodies. We talked about the importance of the CSF, and particularly often really to rule out infection. But it can guide you if you can find an elevation in protein or so on. But you know, this is not specific. So even in the absence of protein, rise of the protein in the CSF, it doesn't rule out neuropsychiatric lupus event. Depends on the syndrome that you're seeing. You tailored your investigation, whether you want to do an EEG or functional or different modalities of MRI, and I will say CT and MRIs. Again, functional MRIs and SPECT and PET, this is more into the research field. But if you have the expertise at your centers, you can definitely use this if it helps you. Now, it's very important, and I plotted this and I say causation, which means the lupus is causing the neuropsychiatric event. We called it early on during the presentation primary neuropsychiatric lupus. So if you achieve this attribution, you need to start your prednisone. And often for neuropsychiatric manifestation, the dose, we call it large dose, it could be anything between 40 to 60 milligrams a day. And you need to stick with this dose for at least 4 weeks. Immunotherapy is important to be started shortly after prednisone. If you delay it 2 weeks until the patient is discharged from the hospital, this is fine, but it needs to be started. Anticoagulation and antiplatelet depends on the mechanism, and we talked about this earlier. Hydroxychloroquine, it's a must, and symptomatic therapy, like I showed you in our patient with antipsychotic management, this is also very important. Now, if what you're seeing, you think it's more an association rather than being a causation, then this is not primary neuropsychiatric lupus, and it's not attributed to lupus activity. So you don't need here prednisone. You probably need to adjust the antipsychotic medication and address other factors that could be related to the neuro manifestation that you're seeing, whether headache, anxiety, depression, or stroke that is related more to atherosclerosis or atrial fibrillation, let's say, not neuropsychiatric lupus activity. And this brings me closer to the management. And we divided this earlier, remembered, with the pathway into ischemic pathway. And this often will require, if you have phospholipid syndrome, for instance, it will require the use of anticoagulation, targeting an INR between 2 and 3, low-dose aspirin for primary prevention of stroke. In patients with lupus with APL, as antibodies, as you know, antibodies is controversial, not syndrome. Now, the inflammatory pathway, it required the use of large dose of steroid, between 50 to 60, and often these patients do receive bulk of methylprednisolone as well, in combination with immunosuppression, whether AZA, MMF, cyclophosphamide, or rituximab. Anti-malaria therapy is a must, and we talked about this earlier. Now, we don't have a lot of drug trials that focus on neuropsychiatric lupus, and unfortunately as well, that until now, patients with neuropsychiatric manifestation are excluded from drug trials. But there was a small trial many years ago and showed clearly that patients who did receive a pulse, in addition to cyclophosphamide, they have a better outcome compared to patients who did receive only cyclophosphamide, and particularly as well the rate of relapse or flare. Now, we know a little bit more about specific syndromes, and I'm giving here an example of myelitis, where there is good evidence around the use already of IV methylprednisolone, cyclophosphamide, and we know in patients with aqua positivity, the use of plasma exchange, and particularly rituximab, to prevent the recurrence of the syndromes. Okay, now I'm gonna shift gear and share with you some of the work that we've been doing at the clinic, and particularly with the focus on cognition. And I'm bringing back, remember, I showed you earlier so far this part of this slide, but now I'm adding here the damage component. And I'm showing the skin to say that probably this is easier than when we compare to the brain, because you can see when we have an irreversible damage, and you know this is you're dealing with scarring, alopecia, hypopigmentation, so you can probably delineate better between activity and remission or inactivity when you're talking about skin or joint compared to the brain. It's more complex. And if you bring an example, cognitive impairment, it's also very challenging. And I'm gonna show you, and you know already that a patient with lupus experience a lot of the brain fog or cognitive impairment. And often we don't know if this is really attributed to lupus or if this is in the context of damage. So this continues to be challenging for us. And I'm sharing here with you two presentation, and I'm sure you have the same in your clinic. You're seeing two young people here, recently diagnosed with lupus, male and female. did have different manifestation, arthritis, photosensitivity, positive antibodies, and early on after the onset of lupus, presenting with cognitive impairment involving different domains. And same on the right side of the screen, this patient did have a lot of activity, but later on the lupus became inactive, and you can see struggling with the same symptoms. So the question here, whether this related to still ongoing activity, as opposed here we're dealing with irreversible maybe damage that could have happened subclinically at the level of the brain, leading to cognitive impairment. And I don't have an answer for this at this level. But if we go back to our attribution model, if we try to score the two scenarios that I showed you earlier, you're going to end up with a score of 7. And remember, we said greater than 7 bring you closer to the primary neurolupus. So you can see here the dilemma, and sometimes our tools here doesn't help us to get closer to the attribution. And this is what I'm saying here again, to remember that greater than 7 what you need, and less than 3 is probably what you're seeing is not related to neuropsychiatric lupus. So as I mentioned earlier, cognitive impairment is highly prevalent, but often the patient in the clinic, they do talk about brain fog. And here we differentiate between subjective, what the patient tells us, or using patient-reported outcome PROM, and what we gather as the healthcare team objectively using standardized measure. And we call it cognitive impairment. And the question, are these similar? We know there is always that there is a discrepancy between disease activity if you measure by SLEDAI, and when the patient talk about what they're experiencing. And we learned a lot lately about type 1 and type 2, but I'm not going to go over this during today's talk. Bringing it back to the cognition, we know that as well there are a lot of associated factors with cognition that can dilute, or we call it confounders, to what you're seeing. Anything can affect cognition, your mood, anxiety, depression, cognitive reserve or IQ, active lupus, the sleep, pain, metabolic syndrome, medication, fibromyalgia, and many other medication. Remember, cognitive impairment is one of the most prevalent. But look at this, 6 to 80, because we don't all of us use the same tools, and we define it differently, and that's creating this wide range of different prevalence. Now, the American College of Rheumatology nomenclature definition of cognitive impairment is significant deficit in any of these domains: attention and processing speed, manual and motor dexterity, executive functioning, learning and memory, verbal fluency, and visuospatial construction. Now, we did many years ago a systematic review, and we analyzed to determine the prevalence of cognitive impairment. And we only focused on study that used a specific tool on how they define cognitive impairment. Bottom line, what we found here, that the prevalence is 38, and it goes all the way confidence interval up to 43. And there is no doubt when we compare it to the general population, means people who did not experience lupus, there is a higher relative risk for patients with lupus to have cognitive impairment. And when you compare even lupus to rheumatoid arthritis, it is higher in lupus compared to rheumatoid arthritis to experience cognitive impairment. Later on, Kim here did the work, and we wanted to understand how people are defining cognitive impairment. What are the tools that they're using? And we updated our systematic review, and we tried to compare on this figure, and I'm going to explain. You see on the x-axis all the studies, and the ACR battery that we know was introduced in 1999, and it went into further validation, and they made it less time kind of burden. And the total time to do it, to perform this battery, is up to 1 hour at this level, while initially it was more. And bottom line here, the dark black color reflect the tests that were described and recommended by Kozora et al. In 2024. But look at what's happening. Light gray color mean the new tests that people kept adding to each of these batteries in their studies. So you can see some of them did use some of the tests in black color, but often there is inconsistency. Even up to 2018, when we did the study, people kept adding new tests on top. And this is always going to generate a difficulty, because when you try to compare things, it's impossible. We also, what we've seen, and you can see on this slide, the way or the modality that we're used to assess cognitive impairment has changed over time. So in the 1996, we used a lot of what we call the batteries. But if you look at the current decade, the outer circles, we see the dark color, which reflect the use of a lot of the computerized tests, and I'm going to show you one of these. And we're using lately short tests like the MMSE or maybe the MoCA, and I will get later on back to these tests as well. So things are changing. Now, back in 2015, when I came on staff, I wanted to start working on cognitive impairment, and many people here are instrumental who helped us to develop this program, and many people over years continue to join this effort. And the criteria were very flexible, as you can see here, and patients are followed over time. So we started back in 2015-16, and we continue to screen patients at T0 every year later on. This was initially at 6 months, but now we're doing this every year. And you can see the current number of patients who did the complete American College of Rheumatology battery screening for cognitive impairment. At the same time, we're gathering information on demographic, different patient-reported outcome, lupus quality of life, lupus qual, SF36, subjective cognitive function with the PDQ-20, depression, fatigue, and we're collecting as well lab tests for cytokines, analytes, interferon signatures, and we're doing as well qualitative studies and some of the advanced imaging with the functional MRI, whether resting and task-based imaging. Now, this is the ACR battery, and as you can see, it clustered in 6 domains in the light blue color, and the yellow reflect the tests that are within this battery. Now, the nomenclature or the grouping that we have adopted here, before talking about this, we have to remember to get the score, you just, it's a way you compare, it's bottom line, it's compared to normative data and adjusted for age and sex, and you get your Z-score. And we defined as impairment if the Z-score is less or equal to minus 1.5 in 2 or more domains. We called unimpaired if you don't have impairment in any domain. And if you did have impairment in only one domain, we called it undeterminate. We did not call it mild cognitive. We just called it really undetermined, because we really don't understand what's happening here at this level. We did use as well the ANAM, or the automated neuropsychological assessment test. So this is a computerized battery that the patient can complete when they come to the clinic. The ACR battery is great, but as you know, it takes time and it's expensive to complete. It involved the involvement of a psychologist to administer the test, psychometrist, and you need neuropsychologists to help you interpreting the results. So definitely it's no doubt it's the gold standard, but probably you need something more practical as a screening test. So the ANAM gives you different scores, but often people relies on what we call the throughput. The throughput, it's bottom line, it's the ratio of the correct answer divided by the time that the patient spent on each of these tests. So this is the battery, the American College, the ACR battery, and this is the ANAM in the dark blue colors. And also you can cluster it in different domains, and it uses different tests. But at the end, you can map things together, the same domain between ACR and ANAM. Now, this year we're going to present at the ACR, we studied the prevalence of cognitive impairment in 360 patients using the battery. And as you can see here in purple color, it's up to 44.3% of impairment. And if you look at the domain 5, which is the dark purple color here, and that reflects verbal visuospatial learning memory. And also domain 3, which is visuospatial construction. But really every other domain is also impacted. And we did try to change the definition here a little bit. We made it more difficult, and we said instead of having 2, we need to have 2.5, the cutoff. And you see when you raise the bar, the prevalence drop, which makes sense. So this is the ACR battery, the gold standard test for diagnosis. But it's important to have a screening tool. When you see a number of patients coming to the clinic, you would like to use a screening test. And if you score positive on the screening test, you can later on move to the ACR battery or the diagnostic test to confirm the diagnosis. So we've done some work over years to try to identify what could be a good test as a screening test. So we started with the ANAM, which I described earlier. So when the patient came to the clinic, they completed the battery, they spent at least 2 or 3 hours of their time with us. They were very generous, and they completed the ACR battery and the ANAM. And later on, we were able to compare these two together. So the ANAM, because this also was a research battery, it took initially anything between 30 to 45 minutes, and the ACR battery, it went from an hour to 2 hours. We did as well the MOCA. I don't know if you're familiar with the MOCA. It's the Montreal Cognitive Assessment Test. It's a very similar to if you have used in the past the MMSE to screen for dementia, but now the MOCA is more used for the screening for dementia. So we did this test to see if it would be a good test to be used in patients with lupus to screen for cognitive impairment. So we've done what we call here the construct and criterion validity to understand if ANAM is a good screening test. And what we found actually, and this work was done by Dr. Tyre Schiffman, she found that there is a good discriminative validity with the ANAM test, which means when you group the patient into impaired and non-impaired, and you look at the ANAM score, those who you find them with impairment, they did have worse score compared to those without. And when you do this, you confirm what you call the concurrent construct validity. At the same time, we wanted to shrink the ANAM, and we've chosen the best test that can reflect the gold standard, and we call this criterion validity. So we shrunk the test from 15 to 8, and later on, using a regression analysis, we developed a composite index that used different variables. Again, the ANAMs give you all these scores, but at the end, you can plug this formula, and it gives you a total, it gives you a number. And as you can see here, I'm going to show you later on, the cutoff 2.7, anything greater than 2.7, it gives you a sensitivity and specificity that what you're seeing most probably reflect cognitive impairment with acceptable positive and negative predictive value, an AUC of 84. And this is the cutoff here. If you put it at 2.5, it gives you sensitivity and specificity of 75. But remember, you can change this cutoff, depends on how you want to use it in your clinic. So if you want to be more specific, you can put the bar a little bit higher here. So based on what we found here, we were sure we have I want to say enough evidence, appropriate evidence, to say that we have evidence around the use of the ANAM as a good screening test for cognitive impairment. Later on, we did a different approach on different set of the data using a type of machine learning analysis, particularly here, the decision tree. And we're very familiar with this in medicine. Bottom line, when the patient complete all the tests, the computer will give you all the interpretation and sees if each of the tests is positive or negative, what's the cutoff, and what's the likelihood that what you're seeing is really related to cognitive impairment. So based on the work that Oshrat and Kim did, we had enough evidence to recommend the use of the ANAM as a screening test in the clinic. We did the same work for MOCA, but I'm not going to show you this, but we did not find evidence to recommend that MOCA is a good screening test for cognitive impairment. MOCA give more weights around orientation, date, and time, and as you know, this is not the problem that the lupus patients are experiencing. They are aware of the time and the year and where they are, but what's more there is the visuospatial, the executive, and memory domain that are impaired. So let's shift gear now. We talked about screening and talk about change over time in cognition. So as I mentioned earlier, we assessed the patient at 0, 6 months, and 12 months. And we recently analyzed the data on 175. And what we found that there is a group of patients always did well and never had any cognitive impairment. And there is a group of 17% almost had always cognitive impairment. And some of them, they fluctuate between impaired and not impaired. up to 29%. And we're still trying to understand what are the differences. But clearly here you can see in red color, those are the persistently impaired group. They had the worst score compared to other in terms of cognitive function. And if you look here at the heat map, the x-axis reflects the time, baseline 6 and 12 months assessment, and the y-axis reflects the degree or the level of impairment. In red color, those are the patients who had persistently impaired function, and you can see they had the lowest score, 1.5 and below. The patient in orange color are the one who fluctuated, and in green on the top with the best score, those are the patients who never over all the assessment had any impairment. Now, if you're wondering whether patients do change impairment between domains from visit to visit, actually they did not. When we look at the persistent, there was actually stability between patient, intra-patient, in the term of the domain that is affected. So I'm gonna shift gear here and talk a little bit about mood disorders, because there is a lot of association between cognition and mood. And we did the same work on and reviewed the literature, and we found high prevalence for depression, 35%, and anxiety, 26% in patients with lupus. Then later on, we worked with Dr. Patty Katz at UCSF and tried to analyze the trajectory of depression in lupus patients. We had included 763, and patients were assessed every year with the CASD. It's a tool to screen for depression, and any cutoff 24 and above reflect depression. And people here, a patient with lupus, they clustered into 4 trajectories. And you can see in the orange color, they're above 25. And in the red color, it's almost up to 35 and greater. So this constituted together 22%, almost 32% of the patient experienced depressive syndrome that did not change. They were in the same trajectory over years, while there is a group of patients who did very well with no depressive syndrome symptoms in green color. Now, we studied as well the factor that could be associated with depressive syndrome. And what we found here, that education is a protective factor. Having low income, pain, and physical functionality, all these could be risk factor to have more symptoms related to depression. Later on, we looked at our data to see the association between depression, anxiety, and cognitive impairment. And we did what we call here at this level an MFA, or multifactor analysis. And what we found, first of all, as I showed you earlier, really depression did not change significantly, because in this analysis, the patient were assessed at 0, 6, and 12. But what we found interestingly, that patient who suffers more of depression, they did have significant impairment in different, what we call complex cognitive tests, particularly executive function, verbal, visual, working memory, and complex processing speed. And later on, we went back again to the data at UCSF with Dr. Katz, and we wanted to study here over years, because we have data over 7 years. How does cognition change along with depressive symptoms? And what you can see here is how patient clustered on the HVLTR, which is a single test that reflects on the recall memory. It's one of the domain. And you see in the blue color, which reflect the worst cognitive function, and this is almost 10% of the patient. The red color, also cognitive impairment, and reflect 20%. So those are the patient, the group trajectory 1 out of 3 that experienced impairment, while 2 and 4 did not. Let's now map this to depression. So CSD, remember, anything above than 24 reflect depression. So group 3, which has the worst cognitive function, did experience as well a lot of depressive symptoms, and that's not a surprise. And group 2, which had no impairment, did have as well no signs at all of depression. But this group, the red group, which also did have cognitive impairment and constituted 20%, did not have depressive syndrome. So you can see here the complexity. Yes, there is an association in some patients with depressive symptoms, but that doesn't explain everything happening at the level of cognitive function. Later on, so what I showed you is trajectory analysis. In trajectory analysis, the groups are forced kind of to join one of the trajectories. But we did later on how things are changing year to year. And to do this, we used a Markov analysis. And what Stefan showed here, that actually over 7 years again, most participants did have stability in their cognition, which means if they had good cognition, they stayed to have good cognition. If they had an impairment, they continued to have impairment. But also, if they had impairment, they were more likely to improve rather than to decline in cognition over time. What we found that, and interesting, that increasing age and level of education are associated actually with cognitive impairment, while signs of depression and lupus activity, they were associated with worsening condition and barriers to cognitive improvement. Later on, Michelle, when she was working with us, now she's back to University of Manchester, she did a type of machine learning analysis which called fusion analysis, where we put all the data that we have together, particularly in terms of patient-reported outcome, and the battery, and try to determine if there are specific groups or categories. And what we found actually, subtypes A and B. Subtype A did have worse subjective and objective cognitive function. They did have as well the worst, all the patient-reported outcome in terms of depression, anxiety, and so on. So in conclusion, subtype A had more cognitive impairment, subjective dysfunction, damage than group T in all comparison. So again, this demonstrates the complexity of cognitive impairment in lupus, and that individual multifactorial phenotypes exist. And the last thing I want to talk about is the utility, the results from our research around cytokines and analytes. So Carolina did this work and tried to answer the question if there is an association between serum, analytes, cytokines, and cognitive function. And you can see here we assess different cytokines. And what we found actually that among cross-sectionally, 2 of them stood out to show some association. And that's particularly S100A8, A9, all calprotectin, to be significantly associated with cognitive impairment. Also MMP9. And if you remember, the S100, A8, and 9 does have an implication on the activation of microglia. And Dr. Betty Diamond and her team in the mouse model, they showed that ongoing activation, stimulation of microglia can lead as well to cognitive impairment, or the mouse model experienced more signs of cognitive impairment. And MMP9, we know that it has, as I said earlier, it can affect the BBB, the leak in the BBB. So it makes sense to find that both these cytokines are actually associated with cognitive impairment. And you can see here the AUC and the AC results. Now we tried to combine all these cytokines to see, can we improve the AUC? Really, it did not. So the main cytokines, again, is the calprotectin, MMP9. And interestingly, what we found with the NGAL, remember earlier I said we had 3 groups, the undetermined group in the middle that had only 1 domain impaired. What we found in this domain particularly, that interferon gamma was associated with the undetermined group compared to non-CI. And we know that interferon gamma occur early in the process. What we concluded, that it could occur or play a role early in the process before the patient has an established cognitive impairment. And interferon gamma might play a role on promoting dysregulation that can lead later on to cognitive impairment. And as you know as well, interferon gamma itself upregulate calprotectin, which can later lead further to activation of the microglia. Now, we did the same analysis, and we're going to present this year at the ACR, but not using the ACR battery. We used the ANAM test, and we did something called here unsupervised analysis. So we did not divide the patient a priori impaired or not impaired. We just clustered the data with the component analysis here. And what we found again, same results, that the calprotectin and MMP9, and in addition this time, I'm going to zoom in here, IL-6, are associated with the green component here, and the green reflected the cognitive impairment. So you can see here, no matter how we're looking at the data, whether supervised or unsupervised analysis, we're finding an association with serum cytokines and analytes, particularly calprotectin, MMP9, and to a certain degree, IL-6. So that was cross-sectionally. Recently, Carolina did as well, Dr. Munoz, over time analysis, and we did have data at 0 and 12 months. And what we found also that, one more time, calprotectin particularly did show the same direction of change like the change in cognitive impairment. So the level of the cytokines got higher and cognitive impairment got worse. And when the analyte cytokines level dropped, cognitive impairment dropped as well. So very interesting results cross-sectionally and over time. We did also try to see if there's an association between type A and B that Michelle described. I showed you this earlier in the paper. And again, we're finding that calprotectin was actually indeed associated with group A. Remember, group A is the group that had everything worse in terms of subjective and objective findings. And the last thing I want to talk about is some of our results as well on association with different immunosuppressant based on our data. But we have to look at this very, very carefully because there is always here bias, no matter how much we try to adjust for this in our analysis. Because these patients could have been started on these immunosuppressants and they are actually for different reasons. They're more sick, they have more lupus nephritis, and probably that's why you used MMF. But regardless, what we found in our data when we looked at ASA, MMF, and we did look also at central acting ACE inhibitor and ARBs, because you know there is an ongoing trial at this level by Dr. Megan Mackay and her team to see if there is a role for central ACE and ACE to protect toward cognitive impairment, and we're looking for this very important trial data results. But in our analysis, retrospectively, what we found that patients who were actually on ASA did better in terms of cognitive impairment compared to MMF. And we found actually no association in our analysis if they are on central ACE or ARBs to protect toward cognitive impairment. But as I said, the ongoing trial by Dr. Megan Mackay and Betty Diamond is ongoing. So what are the take-home messages from my talk today? We talk about different neuropsychiatric syndrome. I showed you some of the attribution model that can help you in the real practice. Pathogenesis and its implication on the treatment, inflammatory, ischemic, and combination of both. High prevalence of cognitive impairment in lupus patients. The utility of a NAM as a screening test, but not the MOCA. The association of depressive symptoms with cognitive impairment. And cross-sectionally and over time, the utility of serum cytokines, particularly S100 and MMP9 in terms of impairment. So at the end, I would like to acknowledge all the lupus group and people who supported this work, particularly patients, and everybody who supported our research. And I want to take this opportunity to invite you all to the Lupus International event that will be in Toronto in May 2025. And I will stop here. Thank you.
Dr. Toma, on behalf of the Lupus Foundation of Jamaica, I hope you're still there. I'd like to wholeheartedly thank you for this comprehensive talk on neuropsychiatric lupus and cognitive impairment in our lupus patients. You've given us as clinicians a very practical template in how to evaluate our patients and manage them. For the patients and the non-clinicians, just to summarize, so it was pointed out that neuropsychiatric lupus is a significant burden to lupus patients. It's important when patients with lupus present with symptoms of concern, it's important to make sure that we evaluate and assign it to lupus, right? Versus noting whether something else could be causing the symptoms you're having. And then the positive that we take away from this talk is that there's a lot of research ongoing so that in the future, we will have a better understanding and better treatments to offer you all. At this time, we could go into a question and answer section. I think we're running a little behind, so we may have to have an abridged one. I have not received any questions. You have? Oh, Dr. DeCoola, we'll start with you.
Thank you very much for this very, very interesting lecture. I have two questions. One is that I learned that IL-6 is elevated in some kind of neuropsychiatric events in lupus, in some at least. Is there any place for anti-IL-6 like tocilizumab or any other in the treatment of these disorders? My second question is that these days people pay attention to the gut microbiome in basically Alzheimer, cognitive impairment, even in Parkinson. Is there any work done in neuropsychiatric lupus?
Thank you for very important questions. And eventually, with the current data that we have, we would like first to further validate the results. And at this level, the association with the cytokines that I've mentioned, particularly the calprotectin, the MMP9, and to certain level, the IL-6 and interferon gamma, are based on the data that we have locally in Toronto. So the next step, we're working now on validating the results in external cohorts to make sure that there is really a good association with these cytokines. And the next step, as you have mentioned, is to use some of the therapies or new biological therapies that can target specific cytokines and analyte, such as the IL-6, tocilizumab, or other. There are no data yet on this. And the second question that you have raised is very interesting because we know as well about the association of calprotectin with Crohn's disease, but I'm not aware of data related with neuropsychiatric lupus.
Any other questions?
Just one quick question. Thank you so much, Dr. Tuma, for that very engaging talk. Simple question. How accessible is something like the ANAM screening tool? Is that something that's free access? Is it something that you'd recommend that we could use? And if so, with what frequency? Or do you administer it if you do in your practice, or would you say in a clinic setting?
Thank you, Dr. Desiree Tuloshrid. Important questions. So the ANAM is associated with a cost. The cost is reasonable, I want to say, but again, this is relative. But there are a lot of actually available free computerized tests that can be used, as long I would say that you gather there is evidence around its use in a particular population here, and we're talking about individual living with lupus. But if I want to bring it to the ANAM, it is accessible, and the interpretability is relatively also available. Once the patient completes the test in the clinic, you can have the score ready for you. Now, how often? Based on the data that we have seen here, things doesn't change very quickly. Particularly, I'm talking here about subjective, yes, cognitive impairment. I would say probably at this level every year or maybe every 2 years can be sufficient.
Thank you. Just as a quick follow-up to that, in a setting where there may not be native speakers of English, I know in the Toronto setting you probably have a mix of that too. How do you find the test performs, or is there a move to find supplementary ways of testing people's cognition that language should not be a major factor?
So, you know, the interesting part about the ANAM and other computerized batteries that are available, Cantab and really many, and the NIH has as well one, that often there isn't a lot of language in it. They're all based on picture that you see, and you really need minimal explanation there about each task that you're gonna do. And I wanna say, I know at least about the ANAM, it's available in different languages, so this is very feasible.
Okay, thank you. I just want a final question, I promised, about sleep testing in your lupus patients. Do you do that often, and what are you finding?
And I knew you're gonna ask me about this. So, no, we don't do, you know, sleep testing in our clinic because the patient-reported outcome that we have, we did not include actually a question around sleep, but you're absolutely right about the importance of assessing this domain. But other colleagues have done, Dr. Katz, Dr. Alkem, and many other people have done a lot of work around sleep in patients with lupus. And we know its application on different aspects of patient-reported outcome, including subjective cognitive impairment.
All right, thanks again, Dr. Toma. Thanks for being here with us. I'm going to hand over back to Mr. MC.
Thank you.
Thank you so much, Dr. Stacey. Another round of applause to Dr. Tumo on your very in-depth and engaging presentation, and for Stacey for leading us through. Okay. Just a little housekeeping. For those who are on Zoom and YouTube, if you have any difficulties, please send a message. And if you have difficulty donating, let us know quickly our donation. I think, Stacey, you will have to take us through the other section because, Dr. McGee, because Dr. Hagley is unable to be with us on that. At this time, I'm going to just ask briefly to a presentation from our sponsors, the National Health Fund and Indus. So could a representative from the National Health Fund come forward? All right. If we're having some technical difficulties, we can do it a little later. But let me just mention our sponsors again, the platinum sponsors, National Health Fund, Indus Life Sciences Limited, the gold sponsor, Wisynco, silver, Stein Cares, and our bronze partners and sponsors, Grace Food, Collaborative Care, Rheumatology Solution, Island Grill, CNS, Massey, and Mocha Island. We just want to thank them. And our partners, give it a run up. Of course, for photography and video services, CNS, and the Uwi Regional Headquarters for the tables, chairs, drinks, AV, screen projection, PA system, and refreshment table cloths is Avant-Garde High Ridge. So we just want to thank, because without their sponsors and the partners, we couldn't have this symposium. So thank you. I'm going to just call Dr. Stacy back to the podium to take us through.
Hello again. I'll be moderating this section along with my colleague, our very able Dr. McGee, but I will start by introducing Dr. Roger Roberts. And the interesting part about this segment is that it highlights the need for multidisciplinary care for our patients, right? That even when rheumatologists see lupus patients, we always have to rely on the expertise of our colleagues in different areas in optimizing their care. So our next speaker is Dr. Roger Roberts. Dr. Roberts is a consultant general psychiatrist and neuropsychiatrist. He presently occupies the position of Senior Medical Officer of the Bellevue Hospital. Dr. Roberts underwent undergraduate medical training at the University of the West Indies, Mona, from 2003 to 2008. In 2014, he completed his postgraduate medical training, his DM, at the University of the West Indies, Mona. From 2014 to 2017, he served as designated psychiatrist for the parish of Clarendon, rendering specialized care to the Maypen General Hospital and overseeing operations of 6 mental health clinics within the parish. Dr. Roberts became a member of the Royal College of Psychiatrists in the United Kingdom in October 2017. He went on to earn his master's with distinction in clinical neuropsychiatry from the Institute of Psychiatry, Psychology and Neuroscience, King's College London in the UK in December of 2018. Upon returning to Jamaica, Dr. Roberts dedicated his expertise to the Kingston Public Hospital from 2019 through to 2023, where he pioneered Jamaica's first neuropsychiatric service, and he continues to provide specialist coverage of neuropsychiatric clinic at the said institution. We are delighted to have you here. Please help me welcome Dr. Roberts.
Good morning, everyone. It's afternoon now. Oh, wow. Good afternoon, everyone. Oh, boy, you guys sound hungry, eh? All right. Thank you, Dr. Davis, for that introduction. Sorry. Slides. Control. Sorry. All right, thank you. Yeah. All right, so I was tasked with presenting on the psychiatric evaluation and management in the lupus patient. A quick overview as to the presentation. In terms of the background, why is it important to discuss psychiatric evaluation in lupus patients, right? That's the first. I'll quickly look at some of the prevalence of psychiatric symptoms and disorder, and I can explain why it's phrased that way later on, and look at the evaluation process. Briefly mentioning about diagnosing neuropsychiatric lupus, which I think Dr. Toma did an excellent job with, and I will finish off the presentation just looking at the management of some of the common psychiatric symptoms in lupus. Okay, good. All right. You guys, yeah, okay. There's something on the slide here. No, that's fine. All right. I think this slide is messing with me with the background dropping off on the slide. All right, so when it comes on to lupus, psychiatric symptoms or psychiatric disorder is quite common. In fact, up to about 65% of patients will present with a psychiatric disorder. Of course, it varies from studies to study. But at the end of the day, high prevalence of psychiatric symptom and disorder in lupus. Now, the challenge is that most time the psychiatric disorder is undiagnosed and untreated. All right? What is the implication of this? Undiagnosed, untreated compromise patient care. It affects adherence to treatment, affects quality of life, and may also impact on mortality, if, for example, in untreated depression, increased risk of suicide. Now, this is familiar. I think that you guys are quite familiar with the 19 symptoms, but I'll just point out there that headache, cognitive dysfunction, and mood disorder, of the 3 most prevalent symptoms, 2 of those are related to psychiatric presentation: cognitive dysfunction and mood disorder. For this presentation, I will be looking at cognitive dysfunction, mood disorder, anxiety, and psychosis. So how common is cognitive dysfunction? Quite common, right? You're seeing a range of about 20 to 80. Of course, this was explained at some level by the first presenter. When you look at how cognitive dysfunction is defined, the different instruments used in studies, the population being studied as well, the adjustment for confounders, you get a wide range. But at the end of the day, it is the most common disorder, and those who work with the patient can appreciate this. The mood disorder is also quite common, depression being the most common mood disorder, ranging up to about 50%. And again, may lead to non-adherence, as I mentioned before, and if untreated, may increase the risk of suicide. Anxiety disorder is also common, up to about 40%. And psychosis, now, when it comes on to lupus psychosis, it's uncommon, not so common, right? But psychosis in lupus is not uncommon because of other issues such as treatment. For example, most people can appreciate high-dose corticosteroid inducing psychosis, for example. Now, these are my thoughts on this slide. No, we don't have the privilege of having access to all those investigative tools that Dr. Toom mentioned. And that is our challenge working in the Jamaican context. I say to you that because we don't have access to those tools, good clinical evaluation is absolutely important. And it is time consuming. At my clinic, I can tell you that sometimes I get the referral. I'm doing the evaluation over 2 sessions, total in about 3 hours. And this is because of how complex the evaluation process can be. It's not the standard psychiatric evaluation where you spend about 45 minutes and evaluate the patient. And I want to go through some of the key considerations. When I get a referral for patients with psychiatric symptom in lupus, there are some key questions that I'm asking myself, and the evaluation process is to answer those questions. So one of the first questions I ask myself, does this psychiatric disorder predates the lupus diagnosis, but was undiagnosed? And I've seen this quite a bit, especially when it comes on to cognitive issue. I think I'll mention it later on, because in our population, we don't do well picking up intellectual disability and learning disability. And I've seen cases where patients present and they say, oh, this may be neuropsychiatric lupus. But upon evaluating the patient has pre-existing intellectual disability. So generally, there's variation in terms of the time frame, but anywhere between 6 months to 2 years, you see in the literature. The important point is that if the disorder predates the diagnosis of the lupus by at least 6 months, it's likely to be a primary psychiatric disorder, likely. Of course, the next question is that, is this a manifestation of neuropsychiatric lupus? And is it occurring around the time the lupus diagnosis, or there's active disease for the lupus? And that's something that we need to tease out as well. The other question is that, are the psychiatric symptoms the consequence of the treatment of the lupus? Or the complications of lupus? For example, someone may have a pain disorder, and you're managing it with opioid, and the patient develops cognitive impairment secondary to the opioid, and not directly a treatment to the lupus. So it can be a very complex process when you try to tease out the different causative factors. And then the last point there, are the psychiatric symptoms a result of a psychological reaction to the diagnosis, the burden of living with the disease, or other adverse life events? The person who has lupus is going through life just like all of us. They're having relationship issues to deal with, unemployment, financial issue, a range of stressor that might precipitate a psychiatric disorder, and it may be totally independent of the lupus. Now, once you go through this, you realize how complex the evaluation process can be. Now, the psychiatric evaluation, and I'm not going to go into too much detail, but just to underscore the importance of detailed evaluation. A detailed psychiatric evaluation clearly is going to look at symptoms, the chronology of the symptoms, temporal association of the symptoms with treatment or disease activity, right? Relieving aggravating factors, a detailed medical history, drug history, including illicit drug use, would be a part of that. The family history, you know, is there a strong family history of psychiatric disorder, primary psychiatric disorder? For example, social history, you know, what's going on? Is this person employed? Are they supported by a family member? Do we have good social network? So all of this is important when you think about the evaluation process, which can be quite time-consuming. And of course, a detailed neurological examination would help to support the neuropsychiatric lupus. The diagnostic process can be quite complex, but clearly, the more evidence you have to support that there's a brain disease involved, then your diagnostic accuracy would increase. I'm not going to spend too much time on the investigation, but just to say that don't assume that the presentation is due to lupus. It can be due to anything, and you should be very broad in terms of your investigation. You're dealing with cognitive impairment. You know, I'm seeing patients turning up with B12 deficiency. These days, people are getting healthy, you know, going vegetarian, they're not eating meat, B12 low. So don't assume that it's because of the disease. Always exclude possible causes. Now, diagnosing neuropsychiatric lupus is quite complex. It's quite complex. I know that Dr. Toma looked at a particular model, but just to note is that they're both diagnosing primary psychiatric disorder and neuropsychiatric lupus, they have something in common. Diagnosis of exclusion. You're excluding things. And that is why the process is so complex to see. Especially in our setting when we are not going to have the benefit of some of the biomarkers, some of the antibodies, we don't have access to functional MRI and so forth. So let's move on to look at some of the common psychiatric disorder, the management. Cognitive dysfunction, not a specific diagnosis, it's really a syndrome. When we talk about cognitive dysfunction, we're talking about decreasing mental ability caused by multiple cognitive domain. And in lupus, some of the most frequently affected cognitive domains are visual and verbal memory, attention, executive function that deals with, for example, your ability to plan, organize things, and processing speed. Now, what is important is that the patient can present with a combination of those cognitive domains. But in about 30% of the patients with cognitive dysfunction, they have isolated domain being affected, a single domain being affected. So the presentation, there is variation in the presentation, I should say. Now, the cognitive dysfunction is not necessarily strongly associated with lupus activity. The person may not particularly having a flare at the time, but they still complain of brain fog and other cognitive issue. And that's to show how complex cognitive impairment is. And then the other point, there are multiple confounders in the patient with lupus that may present with cognitive impairment. So is it a part of primary neuropsychiatric lupus, or is it related to some of the many other factors, including, in our setting, I can tell you that I get a fair share of referral from Dr. Tolereid, and a lot of these patients with cognitive impairment have high levels of depression and anxiety with significant improvement in cognition when those conditions are treated. So look at sleep deprivation, insomnia. There's a big connection between sleep and cognitive impairment, pain disorder, medication, so a wide range of confounding variables. Now, I know that Dr. Tuma mentioned about ANAM. I don't think it's in Jamaica, for sure. But he said something in his study the MOCA did not correlate well with it. And I've seen, I would say that there's several studies that suggest that the MOCA can be a reasonable screening tool, especially if you make adjustment by reducing the standard cutoff score of 26 to about 22. You increase the specificity of the tool. In our setting, we don't have access to ANAM, and I know that Doc asked about it a while ago. And then we have to think about access. It's a computerized software, right, program. You have to think about time. You know, do you have 1 hour in your clinic to do an assessment? So these are practical things in our setting, right? The mini-mental state and the MOCA, they are simple screening tool that can be utilized. The important thing to note, and I'll speak a little bit about screening, right, okay. So the important thing to note is that they're a screening tool, they're not diagnostic. If they're abnormal, they're telling you something, but I want to highlight 2 key points. One is the concept of cognitive reserve. Cognitive reserve, right? When you're administering a screening tool for cognition, think about cognitive reserve. You could get a proxy for this by looking at the educational achievement and the employment of the individual. Why is this important? Because if you administer the test and it's normal, and you've got a patient in front of you saying, Doc, I feel like I'm not functioning, I'm not remembering as well, I'm not able to carry out certain tasks. Don't look at the patient and say to the patient that your test is normal. Because imagine a professor here at the university who probably has an IQ of 120. It's going to take maybe 40 IQ point loss before they have an abnormality on a screening tool like the mini-mental state. So factoring that, if you get a normal result, then refer the patient for further neuropsychological assessment. It's just that the patient pre-morbid IQ is so high, they're losing points, they can feel the difference in themselves, but your screening tool is not picking it up. But clearly, if the tool picks up an abnormality, then clearly it's significant. Not necessarily significant for cognitive impairment, but it might be that there are other issues there, like, for example, intellectual disability or learning disorder, which, believe it or not, we are not doing a good job here in diagnosing individuals with those developmental disorder. So they go through the system and they present in a hospital acutely unwell, and if you don't take a proper history, you think that the cognitive impairment that you're seeing is due to their presentation when it's pre-existing, right? Simple to administer. It's good to get baseline and then monitor the patient as needed. I would say do it for all your patients. It may take 5 to 10 minutes to do a MOOC or a mini-mental state. Now, how can we treat this? Unfortunately, there is no consistent evidence-based therapy for the cognitive impairment that exists in lupus. And that's unfortunate. There are a lot of research ongoing looking at drug targeting the blood-brain barrier, for example, but there's nothing to say that there is established treatment. Medication management may be practical. Now, we know that lupus affects multiple systems, right? If you are on a medication that is causing cognitive impairment, but the medication is needed to treat another condition, it becomes a risk-benefit analysis. You know, and I've said to patients that, listen, let's look at non-medication. Maybe your medication will need adjustment, discuss with your rheumatologist, but I don't think that based on the reason for the medication, adjustment is practical. So let's look at non-medication strategy. But if it is practical and you can reduce the dose of the medication, then that's also an option. Now, management of co-occurring psychiatric disorder, and towards the end, Dr. Toma mentioned about anxiety and depression. I find that in our setting, it's a common confounder in terms of the cognitive impairment, and I've had patients that Dr. Toledo would have referred to me at KPH with cognitive impairment and total resolution once you treat the underlying anxiety and depression. So if we can treat with medication or psychotherapy, that's a decision that we need to make. The general principle is that if the depression is mild or mild to moderate, you can use psychotherapy only. And this might be practical when you think about the lupus patient and the fact that polypharmacy is not uncommon. So if you don't need to add more medication to what you're taking, then I would suggest that go with psychotherapy. And there's good evidence base for cognitive behavioral therapy. Of course, in more moderate to severe cases, then medication would be recommended. I'll talk a little bit about the medication when I talk about the depression. Now, lifestyle changes, we talk about these things and they seem very simple, but there's evidence based to support exercise, proper diet, and social engagement in terms of cognitive functioning. And I think that, you know, as part of the treatment, we should standard practice to recommend social prescribing, the exercise and the diet, especially evidence-based for Mediterranean-type diet when it comes on to cognitive impairment. And then sometimes we are left with cognitive strategies, especially in cases where we may not be able to treat the underlying problem. This may include in helping the patient to pre-plan activities, making lists, reminders, visual cues, and so forth. And fortunately, there are lots of cognitive brain program apps available. And sometimes, you know, I recommend some of those to patients as well. Some are free, some are partially free, but there are many out there. Depression now, the most common mood disorder, there are several risk factors for depression, of course, CNS involvement, comorbid anxiety. The way I always put it is that depression and anxiety, they are married, right? Most people who are anxious get depressed after some time, and most people who are depressed get anxious, right? So high comorbidity rate with anxiety. Recent use of high-dose steroids. Corticosteroid can precipitate any psychiatric syndrome. It can cause psychosis, delirium, mania, depression, and I've seen the full range in our setting. And then psychosocial stressor from various means, and no surprise, they are young age, yeah? Now, the mood disorders were found to be associated with the stress of having chronic illness. It has all harmful effect on the quality of life. There may be physical disability and the lack of perceived control over their illness. Now, this is an important concept here. Very important concept. So when we think about the symptoms of depression, we can think about three groups of symptoms of depression. Group one, psychological symptoms, looking at your depressed mood, your anhedonia, which is loss of interest in activity that you once enjoy, or loss of pleasure. Then you've got the feelings of inappropriate guilt, hopelessness, and worthlessness. Then the second domain, cognitive symptom, talking about inability to think, concentrate, poor memory. And the final cluster symptom, which is important, is the neurovegetative symptoms, which include sleeping difficulties, fatigue, low energy, and changes in appetite. Why is this important? Because studies have found that there's an association between the neurovegetative symptoms and inflammation, right? As in the case of lupus. So it's not uncommon for lupus patients to have those neurovegetative symptoms. Why is this important now? Because sometimes when you're evaluating the patient, when you look at diagnostic criteria, if you don't give consideration to this, you're counting the fatigue or the low energy from the disorder as part of the depression symptom, which, if you look at that note on the slide, do not include symptoms that are clearly attributed to another medical condition. So if you don't take this into consideration, you may inappropriately assess the patient as having severe depression when they do not have severe depression. It's the overlapping of the symptoms, yeah? Now, there are multiple screening tools, and they're very easy to use. I think that it's not a part of our culture, to be honest, to use screening tools. We're trained as clinicians, we evaluate patients. But most of these screening tools, you can get them done in 5 minutes or less, right? Even the PHQ-2, 2 questions. Have you been feeling sad or down over the last 2 weeks? Have you lost interest in things that you enjoy over the last 2 weeks? That's it. If both questions positive, one or both, then you need to probe further. If both negative, it's unlikely that the person has a major depressive episode, right? So there are no more screening tools, and I would love to see the rheumatologist, the GP, and other non-specialists using the screening tools. It's still important for us as psychiatry to use them because they are good for monitoring response to treatment, right? I don't know so clear that one is, but I like the hospital anxiety and depression scale because it's so simple and it gives me information about two things, depression and anxiety. All right, but you can pick and choose and refuse which one you want to use. This is the PHQ-9, looks at the 9 symptoms of depression, easy to use. All right, so patient is depressed. How do we go about treating the patient? Standard practice, psychoeducation. People need to know about their diagnosis, what treatment is available, what is the prognosis. They need this information so that they can share in their treatment plan. I know that some of us are still, well, I'm not saying us, but some clinicians are quite paternalistic in their approach. And those days are done. You don't get compliance with it. You look at patient and say, oh, you need to take this. It's a share plan approach. And if people are going to share in their treatment plan, they need information. So the psychoeducation session is quite important and usually is the first thing. I've mentioned before that psychotherapy, particularly cognitive behavioral therapy, has a really good evidence base for depression, as well as depression in lupus patients. And then we look at medication. So there are two groups of medication that we commonly use. There are others, but the SSRIs and the SNRIs. I know that in rheumatology, and for good reason, there is sometimes the tendency to go for the SNRI because you can get dual benefit in terms of pain management from the SNRI. But it's really about the patient profile and availability. And then at the bottom there, we don't need to overlook it, the diet, the exercise. Evidence suggests that exercise in and of itself is an adjunctive treatment in depression, right? Exercise increases your brain-derived neurotropic factor that helps with brain health. And social prescribing. Now, anxiety disorder, two of the common anxiety disorder, panic disorder, about 15.6% in one study, and then generalized anxiety disorder. The panic disorder is characterized by recurrent, unprovoked, unplanned panic attack, right? That's the key clinical feature. And patients usually worry about the consequence of the attack, that they're dying, they're having a heart attack, and so forth. Can have a high disability if not treated properly with multiple hospital visits, coming to A&E often because they think that they're going to die. Then generalized anxiety disorder, the key feature there is persistent and excessive worrying about multiple life events. Some of these worries are trivial things. You know, you have patients who have never had problem paying their bills, but they're up at night worrying that how am I going to pay the bill next month? So some of the things may be based on reality, real life stresses, but oftentimes it involves trivial things as well. And there are a number of screening tools that can be utilized. Again, hospital anxiety and depression scale, Hamilton anxiety scale, Beck's anxiety inventory. And then quickly, in terms of treatment, treatment is very similar to depression, right? So psychotherapy, relaxation technique, even the absence of full cognitive behavioral therapy can be quite beneficial to patients with anxiety. And medication management, and antidepressant is the mainstay. I would say that it is quite often, or it's not uncommon for doctors to prescribe benzos because of the quick response. It is not appropriate treatment long-term. For patients with anxiety, there's always going to be an increased risk of dependence. If you want to use your benzo, short-term usage, and as a general principle, short-acting benzo that the GP love, like alprazolam, is more addictive than your long-acting ones, such as clonazepam. So bear that in mind, because I know that the non-specialist prescribing, they don't think about the addictive potential, right? And they don't assess the patient and look at the profile to see what is the risk that this patient might become dependent on the drug. So take those things into consideration. And then we're going to wrap up with the psychosis. remember I said lupus psychosis in and of itself is uncommon, depending on the study, but ranges from about 2 to 11%. It tends to correlate well with disease activity, present early in the course, and careful evaluation is needed in lupus because, as I mentioned earlier on, that steroids is a common cause of psychosis in the patient with lupus. So care needs to be taken in making distinction between primary neuropsychiatric lupus versus a secondary cause. And of course, in our setting, it becomes more complex because we're not going to have access to anti-ribosomal P antibodies and all those biomarkers. So again, problems for us, right? The thing about steroid-induced psychosis, which is a feature of drug-induced psychosis, once the offending agent is discontinued, you tend to have rapid improvement. Right? Now, if it is lupus psychosis we're dealing with, and I think that Dr. Toma mentioned this, then immunosuppressive and corticosteroid therapy would have been indicated along with low-dose antipsychotics. And I'm going to underscore that, low-dose antipsychotic. I know that we're used to people on Haldol 10 milligrams BD. Those are not the doses we're talking about for lupus patients. They're usually much lower. In fact, the study will support 3 milligrams of haloperidol as compared to standard dosage for schizophrenia. It's commonly available, luckily, or we have it in Jamaica. There's good evidence base to support it in lupus psychosis. And the second generation, there's evidence to support risperidone, olanzapine, and quetiapine. And all of these medications are available locally, luckily, right? In some cases, lupus psychosis may be refractory, unfortunately, not very common. And for those cases, ECT would be indicated. And again, unfortunately, we don't have ECT at this moment in Jamaica. And I would say that, even though it's not on the slide, that some patients may present with catatonia, and care must be made in terms of distinguishing those patients, because if you misdiagnose catatonia and you're prescribing the antipsychotic, they are at increased risk for neuroleptic malignant syndrome. The mainstay of treatment for catatonia would be benzodiazepine or ECT. All right, so in wrapping up, what are the takeaway points from this presentation? Psychiatric symptoms and disorders are common in lupus. Undiagnosed, untreated psychiatric disorders may compromise patient care and reduce quality of life. The management of the lupus patient should be a multidisciplinary approach, and the non-psychiatric specialist should utilize screening tools. I don't expect you to do that complex evaluation process, but there are screening tools that are readily available, and I think that you guys should start to use them more frequently. And finally, effective treatment is available for the psychiatric disorder in lupus, and with treatment, we have improvement in treatment adherence, improved quality of life, and of course, reduced risk of suicide, especially in the case of depression, which is common in lupus. Thank you all. That's my presentation. All right, no worries.
We want to thank Dr. Roberts for his time and his expertise that he shared with us. He certainly reinforced some of what we heard this morning and added further in terms of the psychiatric realm. And I know we appreciate the relevance of him making the talk appropriate to what we have available here locally in Jamaica. We're going to reserve the question and answer section until the end of the session. So at this time, we're going to move into a quick talk by Mr. V.C. Diane from Indus Life Sciences.
So good morning, everyone. So good afternoon, sorry. My presentation is supposed to be in the morning. It's pushed. It's okay. By Indus Life Sciences, for those who are not aware, we are in 3 Carrift Avenue, Kingston 11. We are a pharmaceutical company, basically. And I don't have any specific product for lupus, but our products are general products, which anybody can benefit out of them. And one of the medication is a pain management. You must have seen the banner that is standing here, which is called as Capsitop, is over-the-counter brand, and it has, this is the ingredients of that. It has a pain gel, one of the ingredients is diclofenac. I'm pretty sure most of you must be familiar of diclofenac, which is for joint pain, back pain, shoulder pain, all it is recommended as a gel formulation. And additionally, it has capsaicin, which is nothing but extract from the chili pepper, capsicum, that is capsaicin, and is found to be very good to deplete pain by inhibiting the mediator substance P. And also it has another ingredient, methyl salicylate, which also reduces or depletes pain by inhibiting other mediators. If you look at it closely, this is not a plain diclofenac gel. This is much superior. It has diclofenac, it has capsaicin, which is the capsicum, that pepper that we eat, and it also has the methyl salicylate. So you will understand it. This is very good for moderate to severe pain, like arthritis pain, rheumatoid arthritis pain. It can be considered. And one caution with that, this is an indication as you could see here. Only one caution is that as it has one of the ingredient, which is pepper extract, the capsaicin, not to rub aggressively, a gentle spread is sufficient. Okay, and of course remember to wash your hands with soap. That's very important, and not recommended kids less than 10 years. Because of the capsaicin. And this slide I don't want to explain much more. You all will understand what does it mean. The relationship between the doctor and patient is so strong. The doctor loves the patient, takes care of the patient, and patient trusts the doctor. But the intruder is the pain. And if you want to eliminate the pain, Capsitop. That's there, right? And we have a spray. This is not a gel, this is a spray, but good news about this spray, this is the all natural spray. There's no chemical on it. If you see the ingredients, you will appreciate it. It has the ingredient first one, which I find it difficult to pronounce it. If I'm pronouncing it wrongly, pardon me, eucalyptus, right? Yeah. Eucalyptus, I'm trying. And it has turpentine, and it also has menthol and methyl salicylate. This is a spray. The benefit of the spray we all know, you just spray it at the area of pain, right? And this is very good for mild to moderate pain, and action kicks in just in a minute. That's the benefit of that. And being a spray, you can use it at daytime at workplace. When you're retiring at bed, you can use the gel, Capsitop. And this is good for moderate to mild to moderate pain, and Capsitop is moderate to severe pain. And we have a nice tagline too for this, just like not only KFC can create a tagline, we also created a tagline, but it's not finger licking good. The tagline is powerful like a real beer, safe like a teddy bear. Yeah, because this is all natural. It can be used in children less than 10 years of age, but to be used by adult, because kids may not know to spray, they may spray in the eye. So as an adult, you can spray it for the kids too. And for neuropathic pain management, this is a prescription brand, which is pregabalin, neurobalin we have, and was good for radiculopathy, diabetic neuropathic pain, general anxiety disorder, post-herpetic neuralgia, all these conditions. And the last brand, which I like to remind you all, is our big juice. It's also referred as Jamaican tonic. That's our amino pep, which is the first supplement in Caribbean that offers vitamins, protein, and mineral, which has 50 milligrams zinc on it. You can notice it, which is ideal dose for immunity. Okay, we are in a world of COVID, so we all need immunity. So this is very good for them, and it's good for any age group. 2 years and above is ideal. Less than 2 years, mother's milk is the best, and pregnant mothers, lactating phase, elderly people, anybody for that matter can take. This is the first supplement in whole Caribbean, offers the best in terms of vitamins, minerals, and protein. And normal dose is 10 ml for adults at bedtime, and children 5 ml is sufficient, 2 years and above. And we have an antacid, which is good for acidity gas problem. I'm not sure how many of you are familiar with this brand. And this is the first brand in Caribbean or in Jamaica of good for acid reflux. Not only for acidity, gas problem, and stomach pain. This is good for acid reflux because it stops acid reflux by a unique ingredient called as alginic acid. This is actually how this antacid works. When you take this antacid, the alginic acid, which is the uniqueness of this, forms the foam, and it floats over stomach acid content, and stomach content move up into the food pipe. It is blocked. N number of attempts it makes, every time it is blocked. And this is formed in just 4 minutes and stays literally up to 5 hours. That means if you are having a nice feast at night and you are taking new gel, you are assured of good night's sleep and sweet dreams too. So that's the benefit of this antacid, and safe in pregnancy, safe in children too, and for everybody, diabetic population can take it too. And this is over the counter, available in all pharmacies. And the extension we have with pain medication, oxytocin, that can relieve gastritis pain also. So this is also over the counter by the pharmacies. And this is the game changer antacid in whole Caribbean. No other antacid come close to the combination and benefit of this. We have it in 200 ml, we have 100 ml, we have 10 ml on the go sachets are also there. And this is actually a comparison of different antacids that you see. And you can see how many Nielsen other brand and how New Gel O stands. Thank you very much. Oh, by the way, you can pick up the samples on the back.
All right, so thank you, Mr. Dand, and thank Indus Life Sciences for their continued support. While I wait for Dr. McGee to come up to introduce Dr. Lee, I just want to tell our participants they can see the program at lupusfoundationjamaica.org/events and just click on program, or you can also access the program at bit.ly/Symposium Program 2024.
Thank you, Stacey. Happy to jump in our session to the multidisciplinary approach to neuropsychiatric lupus. So we've heard from our psychiatrist. Now it's time to hear from our neurologist. So it is my pleasure to introduce to you Dr. Michelle Lee Lambert. She is a neurologist and headache and pain specialist, board certified by the American Board of Psychiatry and Neurology. She underwent her specialist training as in neurology at the Emory University in Georgia and the University of California, Los Angeles, and subsequently pursued a fellowship in headache and pain management. In 2010, she, as a pioneer, established the Caribbean Neurology Pain and Headache Center, the first multidisciplinary pain center in the English-speaking Caribbean. She has expertise in the use of Botox for movement disorders, spasticity, headache, and pain disorders. She provides well-needed services in Jamaica, which include electroencephalograms, EEGs, and EMGs as well. She has over 28 years of experience in seeing patients locally and globally. So she sees patients in person and by telemedicine. And so she's eminently qualified to speak to us today about the neurologic complications of systemic lupus erythematosus, brain, and beyond. Please welcome her.
All right, it's great to be here today, and thank you for the Lupus Foundation for inviting me. I'm so proud of the Lupus Foundation for educating the public and medical professions about this illness that affects so many Jamaicans. So, the first one. How do I go back up? I just want to say, Tanisha said that I was a board-certified neurologist, boarded by the Board of Psychiatry and Neurology. So that means that I had to do a lot of psychiatry, and my board exam, actually half of it was psychiatry. And lupus really is one of the illnesses that shows us why you have to be boarded in psychiatry and neurology, because we're actually two specialties working on the same organ, the brain. I don't think there's any other organ in the body. You don't have two different specialties working on the heart. And that's because the brain can affect neurologically and psychiatrically. So I always want to tell people to remember that Sigmund Freud was actually a neurologist. He was not a psychiatrist. Anyway, so when I was doing this presentation, my walking partner said, "Oh, Michelle, you have to do some jokes, break it up." I said, "I'm not a joking kind of doctor." He said, "All right, but you have to do something." So where did I go? I went to AI. So the first joke, guys, is why did the neuron stay in bed? Because it lost its nerves. All right, hold on, one next. I'm pressing the down, okay. Why was a neuron always invited to parties? Because what? Say it again? Yes, it knew how to make connections. All right, so the serious stuff now. Let's review very basically neuroanatomy, and this is as deep as it's going to get. So the nervous system, you have the central nervous system, which is the brain and the spinal cord, and then the peripheral nervous system, which is just basically the nerves, and the nerves go to the muscles. Nothing more than that. So lupus, systemic lupus, has affected the central nervous system in about 75% of cases. And you see this a lot, Johnson and Richardson. This study was done a long time ago. It was done about 1968, I think. So patients, however, about 90% of the patients will have involvement of the central nervous system and the peripheral nervous system. So in essence, if you have lupus, you're bound at one time or another to have some involvement of the nervous system. So stroke, there's a twofold increase in stroke. And if you're under 50 years old, there's a tenfold increase in stroke. So stroke in the young. So age is the #1 risk factor for stroke. It's a non-modifiable risk factor. Only Elon Musk is probably going to be able to modify that. We're all aging, and there's nothing that we can do about it at this time. So as you get older, you're more likely to have a stroke. So, but young people usually don't have strokes, except if they have other underlying illnesses. So lupus is one of them, and therefore, if you have lupus, you're 10 times more likely than the average person in the population to have a stroke at an age less than 50 years of age. Just to remind you, what does a stroke look like? You have facial drooping, your arms are weak or numb, or your legs are numb, you have speech difficulties. So the risk factors for stroke, these are just the generalized risk factors. And as Dr. Roberts, every time you see a lupus patient, you have to think about everything in general. You cannot just say the patient has lupus and this is the reason why. So hypertension. Hypertension, as far as I'm concerned, is the #1 killer of black people in this country, seriously. This is a modifiable risk factor. Unlike age, we can manage high blood pressure. And that's why you always have to emphasize that patients need to be compliant with their medication. And not because they take their medication and it's okay when they come to the visit, that doesn't mean that they need to stop taking the medication. They have to understand it's something to take continuously. So risk factors for stroke are hypertension, diabetes, which we have a lot again in this population, smoking, high cholesterol, things like atrial fibrillation, obesity, and family history. So unfortunately, this slide is not coming out too well, but in patients with lupus, this is a study, and the number of patients in the study were 50. So 100% of the patients had ischemic stroke in this study, not hemorrhagic. So remember one thing, strokes can be, and let me just define a stroke, by the way. A stroke is onset of acute neurological deficit, focal neurological deficit, that is caused by a disruption in the blood supply. So it's an acute onset, and for some reason the blood is not getting to that particular area of the brain, and when it's not getting there, you're going to manifest it by having some neurological deficit, wherever that brain is controlling, whether it's your arm, your leg, your speech, your vision, whatever it is. So 100% had ischemic stroke. 52% of the patients had antiphospholipid syndrome related, as Professor Harris spoke about, and CNS vasculitis was in 4%, sorry. So the treatment of the stroke is dependent on what the underlying problem is. So therefore, if your patient has antiphospholipid syndrome or antiphospholipid antibody positive, you're going to treat them with an anticoagulant. And if it's from vasculitis, then you're going to give them an immunosuppressive therapy. So I'm going to spend a little bit on antiphospholipid antibodies. This makes your body more likely to form clots. It's seen in patients also who do not have lupus. So you remember the two are not synonymous. If you have antiphospholipid antibody, it does not necessarily mean that you have lupus. However, 30 to 40% of patients with lupus do have antiphospholipid antibodies. 10% of these patients will have antiphospholipid syndrome. This is often diagnosed when a patient has a blood clot or a venous thrombosis, and this is usually in a patient who is young, or if you have a patient that is having multiple miscarriages, pregnancy-related complications. The treatment is with warfarin. So the treatment is not with like the new direct drugs, so such as Xarelto or those new drugs. It's only, the studies have not proven positive, so you have to treat these patients with warfarin. So if they have that, the warfarin, if it's a venous thrombosis, is recommended the INR should be between 2 and 3. If it's arterial thrombosis, it's closer to 3. And then patients with recurrent thrombotic events, the INR the goal is between 3 and 4. And then if it's severe refractory, you can actually add aspirin to the regimen. So another neurological complication we see with patients with lupus is seizures. And I just want for definition again. So if you have, seizures are basically, your brain is made up of electrical wiring, and they're programmed to operate in an organized fashion. There's a rhythm to the electrical connections in your brain. So say it's going on like this, bam, bam. So when you have a seizure, for some reason there's a disruption in the electrical wiring. It just goes crazy. It's an overexcitability, and that manifests itself as a seizure. Now, if you have more than one seizure, if you have 2 unprovoked seizures, you're going to now have epilepsy. Just remember this, that 10% of the population will have 1 seizure in their lifetime and never have a seizure again. So they don't have epilepsy. Epilepsy means that you're having recurrent seizures. When you have your first seizure, you're going to do tests to see what helped to predict if they're going to have another one. So you'd recommend an EEG, electroencephalogram. If the electroencephalogram shows epileptiform activity, potential epileptiform activity, even though they have 1 seizure, you are going to be able to diagnose that patient with epilepsy because the prognosis is high that they are going to have another event, seizures. And so you would want to start medication on those patients. So a seizure just happens when something is wrong with the brain, anything wrong with the brain. Doesn't matter what it is, a brain tumor, a bleed, infection, it can manifest as a seizure. So seizures occur in 0.5 to 1% of the general population. Seizures occur in 14 to 25% of patients with SLE. So again, this is another neurological problem that is more common in patients with lupus. It can be an early manifestation of lupus. It can be caused by cerebral vasculitis, cardiac embolism, opportunistic infections, drug intoxication, and metabolic derangement. You remember patients with lupus often have renal problems. All of this can cause a metabolic derangement, which can lead to seizures. Lupus myelitis. This is not actually very common. It's quite rare. And is her pointer on this? Yes. So this is a sagittal picture of the spinal cord. For some reason, the pointer is not showing on the screen, but pointing on the wall. Okay. So this is your brain. So this is like your body cut in half. So this is a brain stem up here, and this is a spinal cord. This is your cervical spine. And this is the same patient 6 months apart. This is a T2 on the MRI, and you can remember that T2 because the CSF is white. So this is your spinal cord bathing in CSF, and this is your vertebral bodies. These are the like pointy things at the back of your neck. So this here, you can see this white hyperintensity here, this is where the myelitis happens. It should be nice and gray like here. And then 6 months later, unfortunately, this patient had more extensive myelitis. As you can see, the white changing, the hyperintensities, further down, more involved in the cervical spine. So this is what lupus myelitis looks like. It's an inflammation of the spinal cord. So as again, I said it's rare. It only occurs in 0.5 to 1% of patients with lupus. However, it is 1,000 times more likely to affect patients with lupus than those without. There's a strong link between anti-phospholipid antibody and lupus myelitis. 18 to 60% of patients with lupus myelitis have anti-phospholipid antibodies. So when you have lupus myelitis, the symptoms can occur over a few days, actually a few hours or a few weeks. I had one patient, believe it or not, that got up one morning to make her coffee, and within an hour, she was completely quadriplegic. Yes. She could not move her arms and her legs, and this unfortunately was permanent. So you can have weakness in the arms and legs, which may progress quickly. Partial paralysis of the legs, which may progress to permanent paralysis. You have low back pain and sharp pains, and you can have a burning sensation around the waist or wherever the lesion is, and also bowel and bladder dysfunction can occur. So this is a brief case presentation. This is a 32-year-old female with a 4-year history of lupus. And she was doing fairly well, but then she started to have a flare-up of her lupus. She started to have a lot of joint pain, and she had nasal ulcers. Her ANA was positive, and her double-stranded DNA was positive. She had a 4-day history of urinary difficulty urinating. She actually went to the emergency room, and the emergency doctor said that she had a UTI and sent her home with some antibiotics. Well, she woke up 4 days later, completely unable to move her lower extremities. The MRI revealed evidence of transverse myelitis in the thoracic spine. A lumbar puncture revealed elevated white blood cells and elevated protein. Her treatment, she got prednisone, plasmapheresis, and cyclophosphamide. Unfortunately, she permanently had to use a wheelchair despite treatment. This is now cranial neuropathies. And very interesting, I must tell you my experience in Jamaica. I think all the lupus patients are usually diagnosed before they come to see me, but this is the only exception. I get patients who present with numbness in their face. They usually come to me because somebody queries trigeminal neuralgia. So trigeminal neuralgia, not trigeminal neuropathy, trigeminal neuralgia, apart from the patient telling you that they're having facial pain, their neurological exam is to be completely normal. When you examine them, there should be no sensory deficit. So I've had patients refer to me for trigeminal neuralgia, and when I examine them, they have facial numbness. And then they turn out that they have facial numbness bilaterally, and that's always a red flag. If you start seeing things bilaterally, if you see facial weakness bilaterally, facial numbness, you know, people have Bell's palsy, which is really a lower motor neuron 7th nerve palsy, and then you see them have it on both sides of the face. You have to think about autoimmune diseases, and lupus is a big one, and I've actually managed to make the first diagnosis of these patients with lupus. So these are called cranial nerve mononeuritis, and you have mononeuritis multiplex. Also, if you start picking off cranial nerves, if you see patients having a cranial neuropathy, suppose they have an oculomotor neuropathy, and then you notice that they have a 5th nerve neuropathy, and then they have peripheral neuropathy, they're picking off nerves, you have to think about something like lupus. Other things you think about is like carcinomatous meningitis, if you start picking off nerves in different parts of the body. So just to mention 2 lupus pearls, these are big ones for me, drug-induced and movement disorders. And I noticed nobody talked about drug-induced today. So drug-induced lupus, it looks exactly like regular lupus, systemic lupus. However, neurologists used to like to use a lot of dilantin, and dilantin is a big one. So your patients usually have skin rash, and then they have the same musculoskeletal symptoms, fever, fatigue, and the ANA test is positive in more than 90% of these patients. The antibodies are primarily against the single-strand DNA, not the double-strand DNA as in idiopathic lupus. Most importantly, treatment is to recognize the medication and discontinue it. And if you do the skin biopsies, it can look exactly like idiopathic lupus also. So you have to, every time you get a patient with lupus, you have to review and see if it's drug-induced. That's a big one. I think it's about 10%, 1 to 10. Let me just look at my notes. Patients have drug-induced lupus. So other drugs, big on the list is procainamide, hydralazine, isoniazid, minocycline. Those are drugs that also can have drug-induced lupus. Another one, movement disorder. And this happened to be one of my favorite things, movement disorders in neurology. So if you ever see a patient, a young patient, and we will call young, less than 50, who has a movement disorder, you have to think about lupus on your differential. So it's quite common in Korea. And Korea is just looking like a dancing movement. The patient is just moving all over the place. Also, they can have Parkinsonism. Parkinsonism looks like Parkinson's disease, idiopathic Parkinson's disease, which is due to depletion of dopamine. But these lupus can affect the basal ganglia and also cause Parkinsonism. So you remember that the signs of Parkinson's Parkinsonism is arresting tremor, bradykinesia, where the patient is moving slowly, cogwheel rigidity, and loss of postural reflexes, and they stoop. They have a stooping gaze, and they look like they're leaning over forward. Also myoclonus, and myoclonus are just brief, quick, jerky movements. So as Dr. Roberts said, you have to think about every time a patient comes, if they're coming with psychosis, if they're coming with movement disorder, stroking, whatever it is that you think, and they have lupus, you still have to think about all the other things that can cause similar symptoms in the patients. Neurological syndromes at systemic lupus presentation, young patient with stroke, so remember that young patients are very different from elderly people with stroke. It's a whole different ball game. Young people with movement disorders, such as the chorea and the Parkinsonism, patients with cranial nerve neuropathies, especially if it's bilateral, patients with non-compressive myelopathies, and again, patients where they have central nervous system and peripheral nervous system affected. Very important to determine whether neurological disease is due to lupus or some other diagnosis. You don't want to miss other things. And I ended with this. Why do doctors don't make good comedians? Because they're always trying to save the punchline. Thank you very much.
All right, I want to thank Dr. Lee for her excellent presentation. She made a complex topic easy to understand, and we appreciate that. So right now, we're going to do the question and answer section for session 2. There was a question sent earlier by one of our virtual listeners, and they asked, is it lupus alone that can cause neuropsychiatric symptoms, or do other autoimmune disorders do so also, like rheumatoid arthritis, or even conditions such as fibromyalgia? Don't know if you would like to take that on, Dr. Roberts, and maybe I will add, which conditions are these neuropsychiatric conditions more common in?
Sorry. Can you repeat the question?
So our listener was asking, is it only lupus in which we see neuropsychiatric manifestations in autoimmune disease, or do you see it in other conditions such as rheumatoid? And I'm saying, could you also speak a little to which conditions you may see things more often in?
Right. So, in terms of other autoimmune conditions, for example, what? Okay, I think we're good now. Right. Right. In terms of other autoimmune condition, multiple sclerosis is one of those conditions that often present with neuropsychiatric manifestation. As it relates to rheumatoid arthritis, it's more of comorbidity, not necessarily a causation, right? So it's not uncommon for the person with or patients with rheumatoid arthritis to have comorbid depression and anxiety. Fibromyalgia. Again, fibromyalgia is highly comorbid with anxiety, depression, chronic fatigue. So those are common comorbidity, but not necessarily linked in terms of causation.
Okay, thank you for that. Do we have any other questions from the audience? Sybil?
Hi, Sybil. Yes, absolutely. The patient should recover after a few weeks or a few months after you take them off the medication. That's why it's so important to identify this, because basically it's like a cure. You can cure the patient of the lupus if it's drug-induced.
And we have a question from Dr. Kula.
Just two questions. Cannot stop with one. First for Dr. Lee. Again, about drug-induced lupus. If you have say, skin rash related to Tegretol or Dilantin, would you expect it to be early in the treatment, or it can come on late? I give you an example. Some of the patients with lupus are on Dilantin and Tegretol for a long time. If suddenly they have a skin rash, do we have now to think of withdrawing the medication, or just say this is lupus, or how do you go about it?
You know, Dr. DeCoulier, I think that's an excellent question, because really and truly, it doesn't cause idiopathic lupus, but if you are on it, it can, or you have it, it can cause a drug-induced lupus. And so I think about it. Why would you really give a patient a drug that can mimic the illness that they already have? So the answer is, I mean, the common sense answer is you don't want them to be on something that can, even if they never had lupus to begin with, can cause it. So ideally, you really should try and avoid these drugs. But the truth is, everybody that comes to the hospital gets Dilantin. So you really are going to spend a lot of time taking the patient off of the drug. So, you know, this I think comes down to experience, and you might actually have more experience with what you do. I mean, maybe not might be bad to just follow the patient and see clinically how they do. But when they develop a rash, how are you going to know if the rash is from the lupus itself or is it from the drug? And, you know, your goal is to make your life simple. I don't know, Professor Harris, you have an opinion on this?
Yeah, what I would say, my experience with Tegretol, drug-induced rashes usually occur early in the course of treatment with medication, you know, typically.
Now, the second question is for Dr. Roberts about steroid-induced psychiatric manifestations. We accept that if you take 50 milligrams, 60, 40, and so. But now in the gray zone, have you ever seen anybody having any psychiatric manifestations on 10 milligram or 20 milligram of prednisone, or you can rule that out? As a politician say, you can forget it
Boy, I don't think I could be confident in say rule it out. I find that the brain is quite complex, and I've seen patients develop manifestation on doses that you don't typically would expect. But what I would say about drug-induced, steroid-induced psychiatric manifestation, typically the research show, and in clinical practice, you're looking at doses greater than 40 milligrams and above. So your dosage of 10 is not typically associated. But again, it depends on the patient, because if you're seeing a patient on 20 and there is temporal association between initiation of the drug and the development of the psychiatric symptoms, I think you should go with the clinical evidence, really.
You know, it's interesting how you may have so many patients and you give them high doses of medication and nothing happens, and you give a patient a low dose of a medication and they have every side effect in the book. And you know, we're made to believe, we have to believe the patient. I believe when a patient tells me something, I believe it's real. I don't go and say, well, it's a low dose, or I gave this to 100 different people and nothing happened to them, because anything is really possible. I believe that any side effect is really possible. People are unique, so.
If we don't have any other questions, I think I'm going to hand back over to Mr. MacDonald.
Thank you so much, Dr. Stacey, and to panelists, Drs. Roberts and Lee. We just have a couple of tokens I'd like to hand over. Dr. Lee, thank you.
Thank you. Thank you very much. Thank you.
Yes.
Thank you.
Thank you so much again. And we're going to break for just 15 minutes. We have some lovely refreshments outside. And anyone? Sorry. Yes, and maybe after the break. We'll take this short presentation in HF after the break, 15 minutes. Refreshments outside, 10 minutes. We have some merchandise, Lupus. You can check if you need anything and to support us. And we'll see you back in 10 minutes. It's now 1:35. And the question for you, 1:35. And the question for you, why do rheumatologists carry a map? After the break. You know the question? After the break, we'll give you. And could you visit the... So I expect all of you to be back here. We don't want to lose anyone. Okay. You can turn it off and put it back there for me. We'll turn it off. Oh, yeah.
Dr. Kevin Goburn.
Well, what comes to my mind is the role of the brain, the function of the brain, and that lupus can impact the various functions of the brain. I have been coming the journey with ups and downs. Sometimes I'm feeling sad, sometimes I'm feeling happy. I got a lot of support from my lupus family. That's one thing I know. And I
I've argued that I wish my great-grandfather or somebody had written something to tell us, about things in his life every day. I don't understand anything I write with interest.
That's not a common road walk. Yes.
Maybe one of these days. I told you that before.
I know. We were talking about it. Yeah.
It's like you have a publisher waiting, you know.
Ah.
I said, it's like you have a publisher waiting.
Oh, no. I just think the story needs to be told. His story. Your story.
Every time I mention that, so many people because they know you as an administrator, they know you as a this and that, they don't realize that you're a rheumatologist.
It's the best part of my life, Ted.
The rheumatology.
Yeah. Well, while I was doing research,
And you're so right about Dr. Dikula. Everything you know how it is. The patient says, oh, so-and-so, he says, okay, let's check it out. I'm like, okay.
Just an investigator. Everything is a positive.
I love it.
He was the craziest thing I've ever, gone across in medicine,
I know it. Good to see you.
Good to see you. Okay, let me do Tamia. Okay, good.
I give special attention. How are you, Doc?
Not too bad.
Every day he's like the number one like champion. He's promoting the lupus every day. We go, I see him walking.
Well, he received a top award.
Seriously,
on
Dr.
Thursday.
Dikula, what you did, seriously, you single-handedly just really did the space. I mean, it must be
Jacqueline Goldberg. I was diagnosed with lupus in 2008, but I'm sure I had lupus from a child.
My name is Marjorie Allen. Well, I've had this from about 20 years now.
Cedric McDonald, a board member. Dr. Kevin Goldberg, consultant psychiatrist, director of mental health and social services, and individual health and wellness.
Well, what comes to my mind is the role of the brain, the function of the brain, and that lupus can impact the various functions of the brain.
I have been coming the journey with ups and downs. Sometimes I'm feeling sad, sometimes I'm feeling happy. I got a lot of support from my lupus family, that's one thing I know. And I have been trying at least from the beginning to cope, because nobody knows what the illness is. Everybody thinks you have cancer, and that most of the time, but I have to try to convince them that that is not it.
I've had different systemic issues with lupus. I've had lupus nephritis, where my kidneys fail. I've had lupus pneumonitis, where I've had pneumonia. I've had lupus cerebritis, where it affected my brain, and I have had massive seizures. I've been depressed, I've been anxious. I've had those symptoms as it relates to the impact on the brain. I've had lupus affecting my skin as well.
It's pain, mostly pain in the joints. I feel sometimes, not all the time, but especially in lifting things, holding things, make a fist or so. Those are the times when I feel the pain. Sometimes I feel aggressive. Not most times. Sometimes I feel aggressive. And my children normally say that I'm easy to get ticked off, but that's the only negative part of it that I have, because I'm aware of it and I was told so I know it must be true.
I have a good support system. I have my family. My husband is he's a psychiatrist, so I'm married to the right person. So I have that professional help as well as just the comfort and understanding. But they are supportive. I don't think they always understand, and many times they feel like nothing is wrong with me. I've had the occasion where they think I was just seeking attention, and so different family members thought that. But over time, they have learned to understand that lupus can.
I just find somebody who has the same ailment and call and talk to. But somebody who is not negative, somebody who is positive, I find to call and talk to how I feel, and they will tell me that I'm to read a scripture passage and I'm to pray and stuff like that. Well, to tell you the truth, they don't think I am sick, and they don't think I'm having a hard time. They just think I'm tired and want to lay down. They don't think that I'm seriously ill from what they can see of me.
Well, the foundation I discovered much later in my struggle with lupus, but this foundation provides much help in terms of literature, in terms of support. They have a support group that you, as a member, if you're dealing with lupus as a problem, a medical issue, They have rheumatologists as the members of the foundation who can provide help and advice and give additional support. So largely it is a support providing agency for people who are struggling with lupus.
Well, the foundation is everything to me. The support that I get from this organization, it is so tremendous. I feel at home, I feel happy, and I feel well together when we meet, when we all meet, because it's like a big happy family.
I would like firstly for them to not label you. Firstly, you turn up at the facility, they say, oh, this is a psych patient. So nobody takes care of you in terms of your medical aspect, which is what needs to be treated. So I would like them to be more considerate and to be understanding that lupus does have these impacts and to treat you accordingly and not just to banish you to call you a psych patient.
Well, I would tell them that they are to join up with. I'm on a crusade trying to get others who have lupus that I know to come and visit us, because I've been successful in getting one at least. And she came and she was so happy because you get support, you friendly faces, laughter, hugs, and just feel happy, like you're in a big happy family.
So you have to know yourself. Set your own limits. You should know what you can do and not do. Do not allow anybody to set limits for you. Also find out what are your stressors, because different people are stressed by different things. And so know your limit, know your stressors, know your own self, and continue to fight, because there's hope.
What I want is for companies and organizations to come on board with the Lupus Foundation. We are too few in getting support, and we need that. We need more support than what we are getting.
So apart from getting involved in charitable work and then specifically Lupus Foundation, it brings about a kind of fulfillment and happiness. And the best way to enjoy happiness and peace of mind, I think, is to lose yourself in the service of humanity on that. So I would appeal and encourage all those who are listening to this interview to come on board to serve in whatever capacity you can. We have the financial aspect, we have the emotional aspect, and we have the clinical aspect, and also by spreading the word.
Come November 3, the Lupus Foundation will have its annual symposium. This year is making connections between the brain and lupus. And all public are invited to attend this symposium, which will be very instructive, very informative. So invite to come, it's free of charge, and you'll learn a lot from it. So please come in numbers.
Well, first of all, I'm always grateful for the opportunity to serve, because as Ralph Waldo Emerson said, it is one of the most beautiful compensations of this world, that no man can help another without helping himself. So I think that there is a pull that human beings are essentially kind and really want to help other. So I've always known that lupus, and I've served on many charitable boards over the last 3 to 4 decades. But lupus is an extremely debilitating disease. And I admire a lot of the young women who become warriors from lupus, how they have the tenacity to deal with their other life and the life as a lupus patient.
Mental health is essential for your internal good health. But there is no good health without mental health. in any chronic condition, including lupus, to be mentally well is very important. Because by being mentally well, then you can better able to follow the instructions to keep your lupus under control and be able to function within your space, whether it's at school, or at work, or in the home. So your mental well-being is very important, but you are lupus warrior.
Okay, everyone stand by. We still have many persons outside, right?
So you're going to do the NHF first?
I was thinking, yes, just to,
Yes.
to get.
Teeter, chatter.
Hello, ladies and gentlemen, welcome back. We're going to move right into the second part of the program. And at this time, we're going to invite Dr. McLeod to come to the podium. Thank you.
Okay, welcome back to the third session of what has been an excellent conference so far. For this session entitled Bridging the Gap, we'll be shifting gears somewhat and looking outward at different connections, as we know that no man is an island. And so it is my distinct pleasure and honor to introduce our speaker, Dr. Charlene Beckford Jarrett. She's a clinical psychologist and public health scientist with over 20 years of experience in HIV care, research, and program implementation. From 2007 to 2015, she led monitoring and evaluation for Jamaica's national HIV response through the Ministry of Health and the National Family Planning Board. In this role, she played a key part in increasing the availability and use of high-quality data in decision-making for HIV prevention and treatment. Between 2016 and 2024, Dr. Jarrett coordinated the University of California, San Francisco's PEPFAR-funded activity in Jamaica,
further advancing data use to improve the quality of life, improve health outcomes for people living with HIV and other vulnerable groups. Her current research interest is in the intersection of HIV and non-communicable diseases, especially cancers. She's passionate about using implementation science to expand HPV and cervical cancer screening and to promote HPV vaccine and PrEP use among young, vulnerable Jamaicans. Dr. Jarrett completed her BSc in psychology at Cornell University, a PhD in clinical psychology at the University of Massachusetts, Amherst, and an MS in biostatistics at Columbia University. She also completed a NIH T32 funded postdoctoral fellowship, and maybe she'll tell us what that is, in HIV clinical and behavioral research. Outside of work, she enjoys the beach, spending time with her good friends, and raising her 2 children. Now, what she has not said is that she's now a newly volunteer member of the Lupus Foundation of Jamaica, and we are very happy to hear that. She's so definitely eminently qualified to speak to us about her topic, which says, perspectives and possibilities for peer support in lupus patients in Jamaica. So please give her a big round of applause as we welcome her.
Thank you for that very lovely introduction. And thank you to the Lupus Foundation for inviting me. I think what you guys should have picked up is that based on the introduction, I am probably the person in the room who knows the least about lupus. Yes, so it's okay. I've learned a lot though since this morning. The presentations have been really enriching and informative. I'm gonna put the mic on this. So, okay, so I am speaking on the role of peer support for lupus patients in Jamaica. And as mentioned, I'm a new volunteer. I really just got involved in the foundation since this year. But like I said, I've learned so much. And my area of practice, HIV. And so there are lots of similarities already in terms of just the multidimensional nature of the illness and how it affects every facet of life. And so for this session, we're talking about the role and benefits of peer support in managing chronic illness. I'll share an example of a structured peer support program that I'm involved in HIV, and then describe the efforts to develop a peer support training curriculum for lupus in Jamaica. I don't know where to look. All right. So this presentation, I'll build on a lot of what everyone has said so far, the idea that lupus, it's a disease that affects every system, right? So multiple professionals have to be involved. It's beyond medical care. It really involves lots of non-medical interventions if you are to properly control and treat the disease. So for my talk, I want to just invite everyone to think of it in 3 domains: biological, social, and psychological. And they are all interconnected. So disease activity flare-ups in the biological domain will impact on the psychological functioning. That causes depression, it can cause anxiety, and that can lead to social isolation, which then leads to a cascade of withdrawal from care and further exacerbating symptoms. So they're interconnected, so when you're thinking of someone with lupus, you have to think in all of these areas. And the treatment and management has to go beyond medical care and think how else, what are the professionals, what are the support they need in order to reduce mortality and morbidity. Research has identified a number of areas of unmet needs among persons with lupus related to the services they receive and the information that they need. So understanding complex medical regimen, trusting their providers, being able to have open communication with providers, receiving enough information around side effects and treatment, being able to access providers outside of 9 to 5, outside of Monday to Friday, and having assistance with knowing when they need to seek medical intervention. So these are all areas that are identified based on the different research I've reviewed. Over 90% of patients are flagging different areas of unmet needs. And they're not areas that it's reasonable to expect nurses and doctors to address. And so this is where peer support plays an important role, right? So peer support programs, they come from mental health field, and they're also used historically a lot in substance abuse. So folks here probably have heard of Alcoholics Anonymous, right? That's a very iconic sort of peer support forum. But peer support has become more standard and visible in the management of chronic illness because it's becoming recognized that the social aspects are so important to effective management of different diseases. And so you find peer support program across many conditions now. And peers are, I just lost my train of thought. So peers are persons who have successfully coped with the illness. They have navigated the very complex treatment journey. They have lived through and are living with the different side effects. They have figured out ways to manage and handle all the different things that come with having a disease. And then they're now able to share their experiences. They can provide guidance. They provide emotional support to others who are likely new to the journey or who are not as well adjusted. Peers, they don't replace professionals. They don't replace psychologists. They're not replacing the medical doctor or any other professional involved in care. But what they're offering is psychosocial, informational, and practical support, how to navigate the day-to-day things, right? And they're particularly effective because they are seen as being on level playing field. The power dynamics, the things that prevent a client or a patient from asking the doctor a certain question, that's missing, right? And so they're more open, and the issues they might not feel comfortable bringing up with the doctor, they will bring up with their peers. Or the peer will know to ask about certain things because they've lived through it and they have that lived experience to guide how they're interacting with the person they're supporting. So a lot of the effectiveness from the peer support programs, it comes from that level playing field, the fact that they're both living through, or one has a little further ahead, has survived certain things and is able to reach back and share with the peer. How does this not work again? Okay, so peer support is not just something that's nice to have and it feels good and fuzzy. There's actually strong evidence that shows that it is effective. There are certain patients for whom it's even more effective. So newly diagnosed persons who have lots of questions, lots of confusion, they don't know where to go, they don't understand what's happening to them. They benefit especially from having a peer who can help them to understand and to share that experience of hearing and learning of a diagnosis. Persons who have persistent symptoms, who are suffering every day and who they might not have anyone in their daily life who can relate or understand what they're going through. They don't have access to the medical team on a daily basis to talk to. So a peer who is probably living through this and who is suffering in the same way, or who has surpassed that, is able to understand them and able to share in that experience and help them, think through strategies to deal with it. They've also found that marginalized groups, so for example in the States, African Americans and African American women in particularly have high rates of lupus, and they also have poorer outcomes. And they've found in studies where you are comparing response to peer support based on racial groups, African Americans do much better and gain much more from peer support. And so again, the idea of having someone with the shared experiences who is able to relate to what you're going through, who has probably encountered some of the same social determinants, some of the same disparities, they can relate to that and help you navigate it. So marginalized persons, persons who low income, rural contexts, they may also benefit more from social support group, peer support groups. There's also a body of research showing where in different health behaviors and different diseases where peer support has actually led to significant improvement. So there's smoking cessation, there's studies on breastfeeding, increasing exercise, medication adherence, glucose monitoring. Persons who were in the groups who received peer support perform better on all of these outcomes. And then there is one of the more interesting trials that I discovered in my learning about lupus, and I'm happy to share with you. PALS, it's a trial that I believe it's still ongoing, but the early data from its peer approaches to self-management trial, and it's for African-American women, and they've trained the peer mentors, they've trained them in communication, medication management, symptoms, stress management, communication, different aspects and issues related to lupus. And they're paired with mentees, and they, over the course of 6 months, they meet with them bi-weekly, they have calls, and there's a structure to the topics they cover with them. And what they found from the early data is that there's a trend for the women who had mentors compared to the control group who only had social support. There was lower disease activity, lower pain symptoms, and they reported having higher social support. So this is one of the early trials showing impact of this peer support intervention. So we do have peer support models and examples here in Jamaica. There's cancer, there's a breast cancer group, prostate cancer. In mental health, there's some advocacy groups that do lead and support groups for the community, sickle cell, diabetes, and the Lupus Foundation also has, that's a flyer from the page, also has a ongoing support group. And in HIV, support groups also is a big part of the support that persons living with HIV receive. These support groups they vary in terms of the level of structure they have, the modality, so there's one-on-one, where you have a peer that you're matched with, and that's someone who you call, and you guys talk on the phone. Some groups might have WhatsApp chat groups, and you put your questions in or you share in there. Some have face-to-face group meetings. So there are different ways that they happen, and some are also facilitated. So I remember back when I was an intern, I used to be part of a support group in the HIV treatment site, and I was there as a resource person. So I would attend the support group meetings, and if there's a specific topic, I would provide psychoeducation around it. Others are purely peers, and no outside person would be involved in them. So what I wanted to share is describe how in HIV, which is a field where peer and the involvement of persons living with HIV has been a big part of the strides made in HIV, whether it's from ensuring that persons with HIV have access to multidisciplinary treatment teams, the advocacy around funding, the actual development of drugs and treatment, all came from advocacy within the community and persons with HIV pushing for the things that they needed, whether it's medical, social, psychological. So before ARVs, which are the treatment, the antiretroviral treatment for the virus, there's been support groups in different form from very early on. But in the beginning, when there was no treatment, these support groups were really around day-to-day support, helping persons to get daily tasks done, providing emotional support, and helping end-of-life care. Because this is when persons really would get diagnosed very late and likely pass away. As treatment was developed and access increased, the nature of support groups have evolved. And so in HIV now, peer support is much more standardized, and very focused on filling gaps in what we call the HIV cascade. So you're focused on helping persons who are newly diagnosed to understand, accept, and adjust to their diagnosis. You're helping with specific skills to support disclosure to partners, to family. You're helping them with the treatment adherence, ARVs, you have to take it every day. Most regimens now are once a day for life. There was a time when they were much more complicated. And helping just persons to plan for long-term self-management and improve quality of life. On my part, locally, there is a Jamaica network of seropositives, which is a local NGO led by persons with HIV to provide support, advocacy services for persons with HIV. They have what's called a community facilitator deployment program. The community facilitators are peers. So these are persons living with HIV, and they are trained through JN+. This started in 2017. The training is in a curriculum around positive health, dignity, and prevention, helping them to be leaders and training them in different aspects of disease management and effective support. There are 36 community facilitators nationally. My involvement is through University of California, San Francisco. We supported 13 of these peers in Southeast region and Southern region. And we started that in 2019. These 13 persons were exceptional patients, so that means they were virally suppressed, they were taking their medications, they were already very involved in mentoring and encouraging other persons at the sites, so case managers or psychologists would have recommended them to say they can do more, they can help us with some of the other patients who are not doing as well. And importantly, they were willing to disclose their status to other patients. To be matched to a community facilitator, the patients were high-risk persons who were in and out of care. They were not adherent to medication. They were not responsive to the interventions from the doctors, the nurses, or the psychologists. In some cases, they were newly diagnosed, hadn't disclosed, and so they were reluctant to be at the site and hesitated to be involved in different programs. They weren't suppressed because they weren't taking the medications as prescribed and having repeated interruptions. And the social workers, psychologists would approach them, tell them about this program, and if they were willing to meet with someone else, they would be matched to a peer. In terms of the issues, treatment, medication was one of the highest areas where the peers, the community facilities, provided information. So they really helped the peers to understand the treatment. Self-care, condom negotiation, sexual risk management, stigma and discrimination were the other areas where peers provided a lot of information and support to these patients who were matched to them. Other areas on the lower end were employment, PrEP, which is the medication taken to prevent infection with HIV, violence prevention, reproductive health, family planning. So you can see it's a range of areas and topics that peers are able to provide support for. 70% of the peers were matched through these programs, were retained in care, and on ART, and 68% of them have become suppressed. And I'll show you a figure in a few to say this is a significant achievement because these are patients who were not coming to care until they were matched and they were able to be sustained. Specifically, I wanted to say from UCSF, the 13 peers that we supported in the program, they're at Maypen Health Center, Mandeville, Comprehensive Health Center, KPH, and St. Jago Park. And specifically, these 14 persons over the course of the program made over 6,000 calls with their peers that they were matched to around adherence and disclosure, accompanied them on over 1,200 clinic visits. We provide vouchers for nutrition, travel support, and phone cards, and they were able to provide all of these things to their peers. At Mandeville, we were also able to have the community facilitators lead a special intervention for 140 patients who were on a list that showed that their prescription was over 4 months overdue. So they 4 weeks. So for the last 4 weeks, they are not on any ARVs. They were matched to the community facilitators, and they made calls to them, visited them, talked to them. And from that list of 140, 95 were returned to care, and 89 of them retained. And at 6 months follow-up, so 6 months after they first came back, 70% of them were still in care. So the role of the community facilitators was very important in getting these persons back to care, because the clinic staff, the nurses, the social workers, the contact investigators, there are not enough of them to do this kind of work on a consistent basis. So here we have peers who are supporting the clinics to improve the quality of care. In that evaluation of the program, we had different stakeholders, so we summarized their feedback. 93% of the peers were matched in the program, were satisfied with the community facilitators who they were with. The community facilitators, their perspective was that they saw the impact their support to PLHIV peers had, and they were able to support them to become virally suppressed. And in addition, the community facilitators said that the program also helped with their own positive outcomes. And to be honest, for me, I don't have interaction with the patients in the clinic, but I support the facilitators, and hearing their stories, and over the 5 years watching how much they have grown from being in this role and supporting their peers. We have persons who have gone back and finished up subjects, enrolled in degree programs. We've had a number of facilitators graduated from just being a peer mentor to becoming employed by the clinics as adherence counselors or in different peer community, community health worker roles. And so that's been really good to see this kind of empowerment happening for them. And then from the funding agency partner side, we too have seen where the support of peers is in alignment with the national HIV strategy, and it's also just led to the meaningful engagement of PLHIV in implementation. I'd mentioned about the numbers before. This is, we call in HIV, we use cascades to monitor where we are. Of all the persons with HIV in Jamaica, how many are diagnosed, how many are on treatment, how many are suppressed. And the goal is to have 95% diagnosed, 95% on treatment, 95% suppressed. In 2019, when we started, 78% of the estimated population were diagnosed, less than half were on treatment, and just a little more than half were suppressed. So we're not taking credit. The peers didn't do all of the improvement, but they contributed to it, and they were a part of different strategies. In 2024, we're at 90% diagnosed, 64% on treatment, and 75% suppressed. And the peer program, peer support program, over 500 newly suppressed persons would have been supported through the peer support program. So it makes a real difference and contribution in terms of what it is that you're looking for. I have to drink some water. Guys with me? Am I talking too much? Just. Okay, so my lupus journey now, right? So I met with Dr. Tollereed, and we have been working on this project to standardize a training curriculum for peers in the lupus community in Jamaica. And this is based on the evidence I've presented earlier that there really is a role, there's a space for peer support, there's effectiveness, and the persons who are most in need, marginalized, newly diagnosed, having chronic symptoms, would benefit significantly from it. And so what the Lupus Foundation is attempting to do is to develop an evidence-based peer support curriculum for lupus patients. And the content needs to be relevant, it needs to be tailored to the Jamaican population. I mentioned the idea of this continuum. So when we think about tailoring and making sure that this curriculum is relevant, one of the things that we need to understand about lupus in Jamaica, and I don't know if this exists, I did a little lit search to prepare, and there are definitely lots of space for more data, But for lupus, we need to understand how many persons are living with lupus in Jamaica, how many have been diagnosed so far, how many have seen a doctor specific for their lupus, how many are seeing the doctor regularly, whatever the protocol suggests, how many have been prescribed and are adherent to the immunosuppressives, and how many are having low disease activity. Understanding this helps to target the intervention. It helps to formulate the curriculum and to know where and what issues the peers can be most helpful with. For us, the objectives we've outlined for this curriculum is the study to develop the curriculum is to identify the key challenges and coping needs of persons living with lupus. What are the barriers and facilitators to accessing lupus care in Jamaica? What role can peer support volunteers play? What's the current perception? What are the preferences? Do people want one-on-one mentors? They want groups? They want a telephone thing? They want a WhatsApp group? How do you want the peer support program to be? What will meet your needs? And then also we're hoping to gather comprehensive information on the topics that stakeholders believe would be included in the training. For this study, we'll be looking to recruit persons living with lupus, so anyone who's been diagnosed for at least 6 months. We want healthcare providers, so nurses, doctor, the allied health professions that support patients, psychosocial professionals. And then we want other persons, so anyone who's a caregiver for someone living with lupus, anyone who has special insight or knowledge, LFJ volunteers. All of you would be suitable for participating and helping to guide the process to develop this curriculum. The methods that we plan to use in the study, we have a survey that will be available online, and this will be for providers, persons with lupus, caregivers, and it will take 5 to 7 minutes to complete, so very quick. It might take 10, but we're on average 5 to 7, right? We'll also have focus groups, and those will be around 90 minutes, and that will be long, in-depth discussion to help us address the different objectives. And then we'll also want to have one-on-one in-depth interviews with some persons with lupus, some providers, and some caregivers as well. The investigators, we have persons from LFJ, Dr. Tuller Reed, myself, the new LFJ volunteer, Ms. Wyatt Harding, Dr. Duncan, and Janelle, who will help us with managing the data from this. Where is this protocol? It's been submitted to ethics for review. We're hoping to hear back from them soon. And when we do, everyone in this room will probably hear about it. And we're looking for your support because it's clear, listening to all the presentations today from your lived experiences, there's a space for this program, and we want to ensure that all the key persons are involved in helping us to develop it, and to deliver it. So I'm at the last slide. So just summary, I really just want us to remember that the peer support model is not just a nice thing to have. It's not just to, pay lip service to involvement, but it is very important and it's effective. There's data showing the impact it has, and the impact it has, especially on our most vulnerable patients. The training is a critical part because we want to ensure that peer support, persons providing peer support, are able to do it effectively and to do it in a way they're able to not become overwhelmed. They can manage their needs separate from the needs of their peers. And local research is critical to this. It's needed to inform the content and the delivery of this peer support program to ensure that it's effective, it's acceptable, and that it's accessible to those who need it. Thank you. That's my last slide. Which way I go? This way.
Wow, that was excellent. Thank you, Dr. Jared, for that insightful presentation, so clearly delivered, drawing from her experience in HIV and giving us a practical framework for how we can introduce this into our own setting. She highlighted the role and scope of peer support in lupus as a means of empowerment. She told us that it could provide psychosocial, informational, and practical gaps, especially in the newly diagnosed and certain marginalized group. I am particularly excited about the possibilities, and thank you for your perspective. This is certainly something that we should all support, and we look forward to this new curriculum. Are there any questions for Dr. Jarrett? Anything from the... You have a question? Yes. Where is the...
All right, great presentation, Dr. Jarrett.
Definitely.
All right, just a question in terms of the evidence to support face-to-face peer support versus, I'm a bit tired, versus via like telephone or technology. That's one. And have you considered, for example, funding or cost in providing the support? And the reason for this question is that, as you had mentioned, some of the most marginalized people are in need of peer support. And practical, let's be practical, you know, someone living in an area where they have issue with food or paying bills, how do I get to a particular site to get support? I might have to compromise on going for food. Right. I know it's a bit layered, but I think you get the question.
Hi, thank you for the question. So I didn't see any studies that compared different delivery approaches. So looking at, say, face-to-face versus chat versus in-person support. In the HIV example I provided, they used all of them. So I mentioned we made over 6,000 phone calls. So a lot of the support was being able to just have someone to call. And the peer support workers, the community facilitators, regularly checked in. So once a week, every 2 weeks, they made a call. Because what we found with a lot of persons who dropped out of care, they dropped out of care because no one recognized that they were gone. Because there's no one in the clinics who's keeping tab on everyone at each point. So didn't see head-to-head comparison, but just from the program we've implemented, using the calls is very effective because you're able to keep the person engaged and there's an open communication channel. As well, in terms of unmet needs, access to telephone, access to providers, to health information was something that was noted by patients as a need they had. So it fills a gap. The funding question you're asking in terms of if LFJ is going to have funding as part of their peer support program. I don't know. It's something we'd have to look in terms of the resources out there in the world for these programs. That's one of the good things in HIV is that level of advocacy, they've advocated for things. So we need research happening. We need funding to meet psychosocial need. There's advocacy for it. And there's data to drive that advocacy. So in this survey we have, there are questions in there around that issue in terms of cost to access care, and if that's a challenge for persons. So we'll know from the survey that, you know, people that said them can't go clinic and them not have money. So we'll have that kind of information. And then Dr. Tollereed will look into options to provide funding because as in the HIV program, we do provide reimbursement for bus fare, especially for patients who had dropped out and just weren't coming. If we realized this was the issue, the peer workers had X amount of vouchers they could give for food or travel, you know, over a 6-month period until the person was settled. So I hope that answers most of, yeah?
Thank you. Just commenting that's a very good insight. Oops. That's a quite an insightful question, and quite possibly we can rely on Dr. McKee to explore a little bit more when we're talking about the holistic approach. But definitely, and I want to thank Dr. Jarrett again for this wonderful presentation and all that inspiration that we have from her past experience with other conditions. And one of the reasons we're doing the peer support is that it actually can be a way for us for two things. We're trying to actually reach vulnerable groups, and that's one of the ways, so whether it's youth or inner city or rural dwellers, these are the persons that could benefit the most from peer support. We can have these persons as people who are able to provide support, but they can also feed back information that will help us to meet needs better. So it may work out to be quite helpful in a bilateral, in both ways.
Right, another question there.
Online, but within offices, clinics, we plan to have copies available as well. So we might have, I don't remember what was the protocol, but yeah, but we'll have in physical spaces. So at the offices where are the lupus clinics, they'll be able to complete surveys there. So we might have like a tablet that they can use.
Right, thank you so much. That was so interesting and something definitely to look forward to. We're shifting gears a little bit again, and we're going to be looking at a short film. Now it is said, he who feels it knows it. And now we turn our attention to our heroes, our lupus warriors. In this short film, are we ready with the short film? As they share their perspectives on mental health. Before that, though, we have a little something for our good doctor. Thank you so much for your presentation and for coming on board the Lupus Foundation of Dominica. All right, so are we up?
Jacqueline Goldberg. I was diagnosed with lupus in 2008, but I'm sure I had lupus from a child.
My name is Marjorie Allen. Well, I've had this from about 20 years now.
Cedric McDonald, a board member.
Dr. Kevin Goburn, consultant psychiatrist, director of mental health and social services in the Ministry of Health and Wellness.
Well, what comes to my mind is the role of the brain, the function of the brain, and that lupus can impact the various functions of the brain.
I have been coming the journey with ups and downs. Sometimes I'm feeling sad, sometimes I'm feeling happy. I got a lot of support from my lupus family, that's one thing I know. And I have been trying at least from the beginning to cope, because nobody knows what the illness is. Everybody thinks you have cancer, and that most of the time, but I have to try to convince them that that is not it.
I've had different systemic issues with lupus. I've had lupus nephritis, where my kidneys fail. I've had lupus pneumonitis, where I've had pneumonia. I've had lupus cerebritis, where it affected my brain, and I have had massive seizures. I've been depressed, I've been anxious. I've had those symptoms as it relates to the impact on the brain. I've had lupus affected my skin as well.
It's pain, mostly pain in the joints. I feel sometimes, not all the time, but especially in lifting things, holding things, make a fist or so. Those are the times when I feel the pain. Sometimes I feel aggressive. Not most times. Sometimes I feel aggressive. And my children normally say that I'm easy to get ticked off, but that's the only negative part of it that I have. Because I'm aware of it and I was told so I know it must be true.
I have a good support system. I have my family. My husband is he's a psychiatrist, so I'm married to the right person. So I have that professional help as well as just the comfort and understanding. Well, they are supportive. I don't think they always understand. And many times they feel like nothing is wrong with me. I've had the occasion where they think I was just seeking attention. And so different family members thought that. But over time, they have learned to understand that lupus can.
I just find somebody who has the same ailment and call and talk to. But somebody who is not negative, somebody who is positive, I find to call and talk to how I feel, and they will tell me that I'm to read a scripture passage and I'm to pray and stuff like that. Well, to tell you the truth, they don't think I am sick and they don't think I'm having a hard time. They just think I'm tired and want to lay down. They don't think that I'm seriously ill from what they can see of me.
Well, the foundation I discovered much later in my struggle with lupus, but this foundation provides much help in terms of literature, in terms of support. They have a support group that you, as a member, if you're dealing with lupus as a problem, a medical issue, they have rheumatologists as members of the foundation who can provide help and advice and give additional support. So largely it is a support providing agency for people who are struggling with lupus.
Well, the foundation is everything to me. The support that I get from this organization, it is so tremendous. I feel at home, I feel happy, and I feel well together when we meet, when we all meet, because it's like a big happy family.
I would like firstly for them to not label you. Firstly, you turn up at the facility, they say, oh, this is a psych patient. So nobody takes care of you in terms of your medical aspect, which is what needs to be treated. So I would like them to be more considerate and to be understanding that lupus does have these impacts and to treat you accordingly and not just to banish you to call you a psych patient.
Well, I would tell them that they are to join up with, I'm on a crusade trying to get others who have lupus that I know to come and visit us, because I've been successful in getting one at least. And she came and she was so happy. Because you get support, you friendly faces, laughter, hugs, and and just feel happy, like you're in a big happy family.
So you have to know yourself. Set your own limits. You should know what you can do and not do. Do not allow anybody to set limits for you. Also find out what are your stressors, because different people are stressed by different things. And so know your limit, know your stressors, know your own self, and continue to fight, because there's hope.
What I want is for companies and organizations to come on board with the Lupus Foundation. We are too few in getting support, and we need that. We need more support than what we are getting.
So, apart from getting involved in charitable work and then specifically Lupus Foundation, it brings about a kind of fulfillment and happiness. And the best way to enjoy happiness and peace of mind, I think, is to lose yourself in the service of humanity on that. So I would appeal and encourage all those who are listening to this interview to come on board to serve in whatever capacity you can. We have the financial aspect, we have the emotional aspect, and we have the clinical aspect, and also by spreading the word.
Come November 3, the Lupus Foundation will have its annual Symposium. This year is making connections between the brain and lupus. And all public are invited to attend this symposium, which will be very instructive, very informative. So you're invited to come, it's free of charge, and you'll learn a lot from it. So please come in numbers.
Well, first of all, I'm always grateful for the opportunity to serve, because as Ralph Waldo Emerson said, it is one of the most beautiful compensations of this world that no man can help another without helping himself. So I think that there is a pull that human beings are essentially kind and really want to help other. So I've always known that lupus, and I've served on many charitable boards over the last 3 to 4 decades. But in lupus is an extremely debilitating disease. And I admire with a lot of the young women who become warriors from lupus, how they have the tenacity to deal with their other life and the life as a lupus patient.
Mental health is essential for your entire good health. But there is no good health without mental health. In any chronic condition, including lupus, to be mentally well is very important. Because by being mentally well, then you can better able to follow the instructions to keep your lupus under control and be able to function in your space, whether it's at school, or at work, or in the home. So your mental well-being is very important, but we are lupus warrior.
Right. Thanks to our brave, beautiful warriors for sharing so candidly with us. Yes, they deserve a round of applause about the mental and physical health challenges associated with lupus. As always, I'm humbled by their fortitude. Now, as we wrap up the session, we say thank you to our warriors, thank you to Dr. Jarrett, and I'm going to invite Dr. McGee, our consultant rheumatologist from Cornwall Regional Hospital and board member, to lead us into the next session. And we'll invite the panelists to just make their way forward.
Thank you so much. Good afternoon, everyone. This is a home run. Everybody ready? Okay, so this is a segment that we all look forward to, especially our patients, because it's supposed to be really interactive, right? So everyone just get up for one quick second and give a big stretch. One big stretch, say, yay, we're on the home run. All right, great. We are definitely inspired by the voices we've heard, and no doubt some of what they have said today will be food for thought and provide, a place to carry the discussion to that is real and authentic. So in this session, we're talking about lupus for life. So with all the various speakers we've heard since the beginning of the conference regarding the neuro and psychiatric manifestations of lupus, the management and evaluation, this panel discussion is to answer the question, what can we all do in supporting mental health in lupus? So we have three excellent panelists, and I have to apologize for our fourth panelist, Mr. Holding, our medical social worker. He's unavoidably absent. So we have three who have stayed to the bitter end with us, and two you've met already, but one you haven't met, and he's our lupus warrior who I'm going to invite to come to the podium. Let me first introduce him. So everyone is going to give their opening statement, and then we will jump into questions. So here we have Siobhan McLennan. He's a 28-year-old lupus warrior, a proud father of one, living with lupus for 9 years. He's a customer care coordinator and part-time barber. Siobhan is a member of the Lupus Foundation of Jamaica. He's been very active on the ground in Western Jamaica, participating in public education outreach events with his local support group, while staging his own displays and public outreach in his place of employment. To those who know him, he is open and genuine, and so we look forward to his perspectives as he shares his experiences of resilience and mutual support. Siobhan, what's your opening statement? You can do it from there.
So it's an honor, basically, to be a part of this conversation. And while we break down the different stigmas surrounding mental health, I hope that we can come to a collective understanding, basically, and empathy surrounding mental health as well. Okay?
All right, let's give him a round of applause for braving it out. We know that he's unique. Because why? Why is he unique as representing our patients today? Anyone? Male. So we know that lupus, 9 to 10 to 1, female to male ratio, right? So he is unique and can give us some unique perspectives, as well as speaking to the general concerns that our patients have. So we thank him for braving it out and being with us. Now, our other two panelists, you've met them earlier. Just to remind you who they are, we have with us Dr. Roger Roberts, consultant, and the neuropsychiatrist and senior medical officer of Bellevue Hospital. He joins the panel to answer the specific question, are we missing opportunities looking at healthcare providers' role in detecting and addressing mental health risk? Dr. Roberts, who are the we?
All of us. That's long and short of it. I must say, I'm happy to see you participating in this forum for multiple reasons. One of them, men in Jamaica tend to have poor health-seeking behaviors, and the fact that you're here representing in this way, I think it's commendable, right? Now, when it comes on to mental health, and I think that Dr. Jarrett touched on a model that we like to promote in psychiatry, which is biopsychosocial model. As a psychiatrist, people may think that, okay, I am responsible for mental health, but mental health is interconnected with medical issues and social issues. And therefore, when you think about the nature of mental health and the nature of lupus, then the we is really everyone that interfaces with the person living with lupus, and as well as the person living with lupus. It ranges from your GP to the various specialists that manage the patient, psychologist, social worker, and that's the way. We all have a part to play, and even the general public and society have a part to play, because stigma and discrimination from the general public may be a barrier to people accessing care for mental health. So the we is all of us.
Thank you so much. Thank you for your opening statement as you answered my question. We welcome back Dr. Charlene Jarrett, Senior Researcher, Caribbean Vulnerable Communities Coalition. We just heard from her on the importance of peer support. And so, Dr. Jarrett, what's your opening statement? As you look at the role of research and policy, lupus in community, educational, and occupational spaces.
Hi again. Good to be back. So actually I have a story for this one. So I was at an event last night, and I was with a colleague who's a senior person at Ministry of Health, and I mentioned to her that I had to leave early because I was participating in this forum today. And I was on a panel, and she asked, what's a panel? I said, research and policy for lupus, something, something. And her response was, what's the prevalence of lupus in Jamaica? Because, that's information I need if I'm going to add this to one of the priority diseases and start focusing on policies, and so on and so forth. And so I said, this is exactly what I need to go back and say tomorrow. To advocate for policies, to advocate for resources, services, interventions, you need data. Right? And so in the lit search that I did, just looking at publications from Jamaica around lupus, there are so many spaces and areas that we need more understanding of in order to advocate for the appropriate policies and the appropriate interventions. And of course, I have to reference HIV, because that's really where my work has been. That's an area, field where research has driven and continues to drive the program here in Jamaica. So basic epi research, surveillance, every population, understanding the dynamics of the epidemic, transmission, who's affected, where, when, how. That data and research continues. I put up the idea of the cascade. So there's research happening around all the pillars to understanding barriers to coming to care, barriers to linkage, barriers to retention, different outcome, who performs better, who does better on treatment. All of that's needed. The data in Jamaica has also guided advocacy and outreach efforts, so prevention campaigns, knowing to target young men of a certain age group, women of a certain age group, to say these are persons who need greater awareness to practice certain prevention behavior. Looking at stigma, understanding the drivers of stigma against persons with HIV, that's research. And so for lupus, there's a need for greater awareness, because prior to becoming a volunteer with LFJ, I didn't know that much about lupus. And once I joined, I started recognizing how many persons in my personal life and entire families, all the sisters and moms, have lupus. And more awareness around that is important. And that's where research is needed to understand the gaps in what we know, to promote it. In school settings, the cognitive issues came up in Dr. Gibson's and the keynotes address. The cognitive issues, those are things that are going to affect your functioning in school and in workplaces. But we need campaigns, we need educational drives so that teachers, employers, colleagues understand the issues, so that if policies around accommodations are needed, those things can be based on data and have justification. So I think my opening remark is, I think a lot of research can and should be done so that we can start advocating for policies and services that are needed.
All right, so Dr. Jarrett, you actually started the discussion, and that's great. That's great, because your last slide pointed to the fact that we do need data, and a simple thing such as the prevalence of lupus in Jamaica.
Where do we begin? Sometimes the perception is that clinicians are too busy, there aren't enough resources, the skill set, grant writing, for instance. You have so many years of experience and you publish. Where do we begin in the lupus world? You can extrapolate from HIV. Simply, simple roadmap.
So I agree, clinicians are busy. So I wouldn't put it on the clinicians to lead this drive, but this is where collaboration is important, and this is where mentoring is important, because this is where you use a network to accomplish the tasks that are needed. So for thinking through some of the work I've been a part of, grad students. So for a time, I supported the clinical program here, and every year, one of the grad students would be steered towards an HIV-relevant piece of research. And there's several grad programs here where activities around lupus, and from many dimensions. So it can be clinical. There are DM candidates who can probably do work that involve lupus, as well as community psychiatry. There is the clinical psychology, the health psychology programs, social work programs. So there are so many spaces where relevant research could be happening, and that can be done in collaboration with clinicians at the sites, because that's where you can get permission and approval and access to actual patients who would be able to support that. As well, I think the LFJ could play a role in that through the volunteer network. But again, it really requires collaboration. I wouldn't say that clinicians will need to lead these, but where can you network and begin to collaborate with persons who are doing research and who have a need to do different studies?
Yeah. So, Dr. Roberts, I'm going to ask you to jump in on that in terms of, research, certainly with your experience in psychiatry, actually being able to get it done. Any comments?
Yeah. Dr. Jarrett, cognition came back, right? All right. So just to jump on something that she mentioned about, the person in ministry mentioned about prevalence. I know that is basic and important data for us to have. But when you think about support, it goes beyond prevalence. You have to think about the impact of a disorder. And when you think about lupus, 9 in 10 affected are women. And what role women play in our society, right? Most households, unfortunately, are headed by women. They're the carers to older parents and so forth. So you have to think about the implication on the population that we're dealing with, and not just prevalence, but the impact, right? Now, as it relates to research, I think one of the challenges I have, and I don't know if it is an issue with the various universities, but in many jurisdictions there is a better partnership with corporate society and NGOs and so forth, and you find that you get more buy-in in terms of supporting research. Because the reality is that good quality research usually requires some level of funding. Of course, we have, as Dr. Jarrett mentioned, there are various university programs, postgraduate programs, and most of these programs, as a requirement for completion of the program, you will have research being a part of it. But a lot of these research may be restricted to basic descriptive type study. And some of the more robust study that may be helpful may require funding. And I think that we need to have discussion as to how we can improve on partnership with corporate society and NGOs to get better quality research.
Gotcha.
Yeah.
All right, I want to go to each panelist looking at your specific area that we outlined under the general theme of collaboration and patient empowerment, promoting resilience. We've touched on research. I want to go to our lupus warrior. resilience, the capacity to withstand and recover quickly, toughness. So those are some of the definitions, Siobhan, and you embody that. But the journey has not always been like that. Can you share with us your own journey with mental health concerns and how you've been able to change gears to the point where you can provide support to your peers?
Well, I don't even know where to begin, basically. It's been a journey, though. It's been a journey. What I can say, though, is that I think it gets easier, but it doesn't. What happens, it actually becomes more manageable. When I say manageable, you kind of figure out how to maneuver the different challenges you actually go through as it comes to lupus as an illness, as well as the mental part of it as well. Because, as you know, it's incurable, so you're going to have to be taking medication every day for the rest of your life. You have to be dealing with the different challenges, physical challenges that it actually brings to you, basically, and as well as other things that would actually affect you mentally, in which you are unable to do the regular day-to-day stuff that you would do, and that can have a toll on you as well. You're unable to participate or go as the extra mile as you would normally want to go. So it's been a journey, and being more aware of the different effects it have on you physically and mentally has given me the ability to actually manage it more, basically. So that journey, though, coming from start, learning about lupus, because when I got diagnosed, I did not have much information on it. And between my personal experience and researching and speaking to other persons who had lupus or have lupus, I've actually learned to manage it more, basically.
How did you get to the place where you can tell us about supporting others? What gave you that ability to? Was it the increased knowledge, awareness, being able to manage it more, confidence, or is it just the desire to help? What makes you want to support and be able to support effectively from the stories that I've heard about you?
Well, in terms of supporting persons, when I just got diagnosed with lupus, it took me a while to actually accept it. And when I accept the fact that this is what life is now for me, basically, I actually got more open about it. I got more open in which I could talk to people and say, hey, I have lupus. I can say it more freely. At first, I wasn't able to just say, oh, I'm unwell, so I have lupus. I would actually hold it back and internalize it, basically. But after being more open about it and actually accepting it more, it actually opened my eyes to a lot of the other things that persons are actually experiencing. And that was where I could actually say, let me help this person or let me talk to this person. Because even outside of lupus, there are so many other things that persons are going through. And with my experience, it gave me the opportunity to actually understand more, where I can even stretch out to persons with other medical illnesses or persons that are just experiencing mental problems or daily depression and such.
Thank you. Dr. Roberts, I want to talk to you about the we in the context of addressing stigma. Before I ask you about the we and addressing stigma, on all levels, healthcare levels and so on, I just want Siobhan to close with the umbrella story. It's a nice segue into Dr. Roberts' response.
Okay, so there's this umbrella story, right? I was at the hospital one day and Dr. McGee saw me and I didn't have an umbrella. It was like roughly early mid-afternoon. The sun was really hot. And as a lupus patient, you have to have an umbrella. I didn't have an umbrella and she gave me hers. And going forward, I started ensuring that I have that umbrella every day, being that it was a gift from her directly as well. So about 2 days after, I was walking in the town and I had the umbrella. Mid-afternoon, sun was hot, and a man saw me, a gentleman saw me and was like, watch him when I walk with the umbrella. And I couldn't even answer him. I had to just shake my head and laugh and be like, you wouldn't even begin to understand the different challenges. He wouldn't, if I tried to explain to me, he wouldn't even understand. Because a lot of times I try to tell persons that lupus is there, this is what it is, and they don't know. A lot of persons don't know. I remember once someone, I had like the same sun situation, and it started showing on my skin. And someone asked me what was wrong with me, and I said, I have lupus. And they said, is it something close to cancer? That time I wasn't so open about talking about it, so I just said yes. And he was like, so where are you working? Where are you outside? And I'm like, I have to support my family. So a lot of unawareness plays a major part in persons actually internalizing the illness, basically.
So, Dr. Roberts, stereotypes and stigma. So, man walking with an umbrella, male having lupus. We see it in the public. Does it play out itself amongst healthcare workers? You know, things like internal bias, and how does it affect our ability to deliver the kind of care that we need in a holistic manner?
Right. So it does play out in the healthcare. And I think back to Jackie's story in the video, where she said that they label her as a psychiatric patient, and that's something that she spoke about. There's a concept of diagnostic overshadowing. So when someone has a mental health problem and they present, the healthcare provider has this bias to attribute their presentation to their mental health. And in doing so, they neglect the physical problems that the person may be having or maybe presenting. So, and that is well researched and documented. So that bias exists in healthcare workers. As it regards to Chevron, I think it speaks to sociocultural issues. It speaks to the issue of health literacy and the need for health promotion. So if you're going to combat stigma, you can't keep silent. Right? You have to have a voice. People ought to be educated about the condition. I think Siobhan is at a good place because what it sounds like is owning the illness, which is like calling. When you own your illness, you can go into spaces and talk about it freely. It's not easy because I'm sure that gentleman saw you wondering, you know, you're in a forum, you probably don't say it. This man, my girl, or when I walk with umbrella. The whole thing, right? So then your role is being challenged in different way, you know, in terms of gender, because people are lacking the information. And then what you have underscored is important, that if someone is not in a state of readiness to access information, you getting into a conversation may be pointless. But it takes years. It's not something that you change overnight. It takes years of social engineering to change people's idea and perception about healthcare. But the more spaces you have in dialogue in, definitely it's going to help. And I think that when you think about common places, let's think culturally, schools, it started at an early stage, places of worship, churches, those are common places. And then you have other social groups. So the more space you have in this discussion, you will be able to combat stigma. Of course, as physicians, we should all be mindful of biases when we relate to our patients, and I'm sure that that is something that should be a part of any undergraduate and postgraduate curriculum, because there are certain groups that may not be in keeping with the predominant social-cultural expectation, and there's going to be that inherent bias, and you have to overcome that as a clinician.
Dr. Roberts, I want to talk about the typical clinician. We'll change gears now and talk about the typical doctor, primary care doctor, seeing a patient with diabetes. They don't come in for, complaints of having anything to do with mental health. What are some of the red flags in a busy practice on a typical day that one can look for to suggest, this person perhaps needs to be screened?
Yeah. So that question is a good question, and I tell you what. In most cases, the doctor may not see a red flag, and I'm going to tell you why. When you think about the model of care in our primary health care system, most of the time, the doctors, especially junior doctors, the senior house officer or a medical officer, they rotate. So they don't establish that relationship with patients. For example, my private patient, they can come in today and I can look at them and know that they're unwell because I know them. I'm seeing them consistently. So when you have this model where you don't have an assigned care provider and the frequent changes, you don't get to know your client very well. That's the first thing. A lot of the mental disability, they're really silent in a sense, you know, especially to the person who hasn't got experience. I'm able to look at a patient face and say, well, based on the affect, this person is depressed. A non-trained person may not have that ability. And because of the culture that we don't have safe spaces to discuss mental health, the patient may not feel comfortable to divulge that information, right? And this is why the ministry has moved towards screening in certain at-risk population. And you mentioned about diabetes, for example. They have been trying to promote screening for depression in that population because they know that mental challenges, particularly depression and anxiety, they're quite prevalent in NCDs. And I think that a similar model for lupus, you know, I think we should be thinking about screening. You cannot diagnose something that you don't entertain. A basic principle in medicine. Right? It sounds very simple, right? Mm-hmm. So if you've seen somebody, you don't think about their mental challenges, how are you going to diagnose it? How are you going to pick up that there's a red flag? So you should be thinking about, based on the discussion that we had earlier today, about the high prevalence of psychiatric symptoms in lupus. So when you're seeing a patient with lupus, you should be thinking and asking yourself, is it possible that this person may be having depression, anxiety, or cognitive issue? And once you're asking yourself that question, and there is some policy where there is standardized screening tools that we need to agree on, you go ahead and administer the screening tool. But then it brings now the ethical issue of screening people. Because if you screen people and they're positive, what do you do with the positive results? So it speaks to service development now. What kind of care pathways that we need to develop for people living with lupus? You're positive, where do you go? Positive for depression. Is it that there is going to be provision put in place where your primary care doctor can manage to a certain level, or off the jump, you should be referred to your local psychiatrist for management. So we need to talk about the development of care pathways. Once patients are being picked up as being positive, what do we do with them?
Thank you, Dr. Roberts. I'm going to throw it to the audience for any questions. Do you have any questions for our panelists? Any comments, any observations, anything you want to share that you think might be enlightening and of benefit in this conversation?
I'm not sure it's going to be either enlightening or helpful, but you know, I wanted to talk a little bit or comment about the research into prevalence. I think lupus is particularly challenging because if you have somebody say diabetes, okay, it's diagnosed, your blood sugar is this, and the diagnosis is made, it's the same diagnosis everywhere. Lupus now presents to different people, so there are some coming to dermatologists who never go to the rheumatologist, and there are some in private, so they're all over the place. Not only that, it takes so long before a diagnosis of lupus is made. So the prevalence, just to coordinate that, wrapping your head around it, I find that it's going to take a concerted effort, a good structure, a framework to get that real prevalence, because we're always going to be underestimating the prevalence of lupus. We already know it's high, which, as you say, for the Ministry of Health person, we already know it's high. From 1979, we knew it's high. So they don't have to wait for a new study to get going. We know it's high. We do need new studies to get more accurate figures. But that in itself is a challenge that I don't know how you could see for this particular disease. How would you approach that?
Thank you so much, Dr. McLeod. And Dr. McLeod has years of experience in dermatology, seeing a lot of our patients. So We fully take what you say. That is definitely a concern. Yeah.
There was a so I can comment on the so in terms of the prevalence, and you're Roberts. Sorry for giving. I'm sorry.
That's right.
So your response is actually how I responded, and then I said, Charlene, go home. Like, don't start a big debate. But, you know, it's the prevalence is important because it helps us to understand the scope and start thinking how many persons are unreached, right? But the impact is really important. But so in terms of doing prevalence, it's not, you don't have to count every single person with it. There are models and ways to estimate, and so even the next iteration of our prevalence study for lupus will need some modeling. It will need to, you know, pick up on the rates for the ones that we know and then extrapolate from there. So it can be done, and it needs to be updated because that's where you're going to start understanding, okay, we said it's 6,000, but when we look at these data coming from the different clinics and incidents, we could be closer to 10, 12,000, which means there are probably 8,000 persons who are not in any kind of care. And so it is important for that, but it's not the sole basis by which it should be prioritized as a national health issue.
Dr. Toller-Reed?
You can hold on to this one, I'll share.
Thank you so much to all the panelists for sharing our insights. I actually had a question for each person. I have a question for each person. I wondered, and really thank you so much for sharing, sir. You know, from the, as you said, from the ground, and so you are already doing peer support. You are known to be one of those persons who is seeking out others and encouraging others. Is there any way in which you would, if you wanted to continue that, or if you wanted to get other people to do that, in what way would you want to be empowered? What kind of information or skills or resources would you want? I mean, following up on the question Dr. Roberts asked.
What skills I would want?
Yeah, what would you want? You know, you heard Dr. Jarrett talking about a peer support volunteer training. I'm not trying to preempt your needs assessment, but I can't resist asking, would something like that, an actually formalized way of actually preparing people to do peer support, would that be helpful, or what would you want to see done about that? Mental health.
So I was actually thinking about it when she was doing her presentation, and I thought it was a really good idea, basically, and it would be something that I would be interested in, because just to also touch on what she also mentioned as well is a lot of times persons have symptoms because they don't know about lupus, or they don't. For me personally, I think I had lupus years before I actually got diagnosed, and I've been going to a lot of doctors with the same symptoms that I've experienced while I have lupus, and it's always something else. It's always pain pill, take this, take that. They never really target lupus by itself until I got referred to see a specialist, and then I got referred to Dr. McGee, and then she said, okay, it's lupus Chavant. So in terms of what you mentioned, though, at my workplace the other day, I sent out an email in which I advise persons that I have there's a setup with pamphlets showing the different symptoms of lupus and how it affects you and such and such. I advise them that if you think you have any of these symptoms and if you are experiencing anything such as those, you can either come talk to me, or you can see a doctor and explain to them that you want to check. You want to explain to them that you are having symptoms that is similar to lupus symptoms, basically. So in terms of tools to actually promote the peer program and awareness for lupus, it's just to reach out to the public, basically, because I have the necessary knowledge that I need already, I have the experience, and I already have the drive to help and the drive to reach out to persons, basically. So it's just to provide awareness and reach out to the public, basically.
Thank you. I don't want to take up too much time, so I will leave the rest. But Dr. Robert, I'm out there in the clinic rushing too, as Dr. McGee was saying. Maybe they're encountering nurses, they're encountering pharmacists, they're encountering different people, and somebody on the video was saying that, you know, here are the meds, next, you know, so what should we be doing based on what you were saying today to detect if somebody's having a challenge, and what should be the next step? You know, for us out there, we're not non-psychiatrists, but we're encountering people. And if what the patients have shared was so true, what can we do? I just wondered what your comments were on that.
I think I mentioned some of it already. First of all is to be guided by the data. We know about the high prevalence of mental health in lupus. With that knowledge, I think that you should have a clinical suspicion when patients present. And in your own practice, I think that you should have some screening tools available. I don't expect you to go through a detailed psychiatric evaluation. It's very time consuming, but at the very least, if you have basic screening tools, that should help, and know the pathway, the care pathway for your patient. So I have a positive screen for depression or anxiety. What am I going to do with this patient? You have to work that out beforehand.
In closing, we talk about collaboration and we use the word we. We're living in an era where you talk about even social integration and part of the care of psychiatric illnesses being socially connected. We're living in a social media age where everybody thinks they're connected, but we're actually more disconnected than we've ever been. Is that so? And how does it impact each of you in your roles, you know, as we think about empowering and spreading information about mental health in lupus?
Right. We are all connected, but I'm not sure we are connected properly. That's the problem. You know, when you think about social media, if you try to seek out information in the wrong place, you're going to have 150 different opinions. Some aren't very helpful. Some may actually worsen your mental state. So one of the things I would say that when we talk about connection, we're talking about utilization of community resources that are available, that are established and has some sort of a protocol. For example, for mental health in Jamaica, Mensana, you spoke about Alcoholic Anonymous. I don't know if they're still up and running, but we have them in Jamaica, to be honest. And it's about connecting to establish resources in the community. Now, of course, when we talk about social connection, it's not just about those formal organizations. Sometimes people will come to me, and for them, because of their depression, they has not been to church, for example. And it's just about getting back the person in that space, seeing their friends, worshiping, and it has a positive impact on their mental health. So you have to take into consideration what resources you have available locally. There are some, there are loads of online support groups. I'm sure that if you're going to join one of those, you should do your due diligence and seek out. In a Jamaican context, I know you mentioned about peer models, right, where there's no facilitator. With my experience, I would say that I would prefer to have a facilitator, even if the person is not heavily involved in the process, which they should not. But there's a lot of misinformation in our culture, and people may say unhelpful things that actually harms people's mental health rather than improving it. So those are some of the things that I think that we ought to consider, right? Non-medication strategies, exercise, meaningful exercise. Doesn't have to be that you join a gym, right? Dancing, watching videos and dancing and so forth, various forms. I always say that we don't appreciate some of the resources that we have locally, but we see people jump on a plane and they come to Jamaica and they go to a river, or they go somewhere up in the mountain and enjoy nature, but we just disqualify those things. And some of these things that are pro-mental health, they don't have to be expensive. You know, we're living on an island, right? A quick drive, most places there's a beach. You have the sea, you have rivers and so forth. It's about utilizing your local resources, and it doesn't have to come at an arm and a leg, right? Oh, it's a good question. I think I touched on that. So there is the MH Gap program where they're trying to improve screening and treatment of certain mental condition at the primary care level. For example, an MO in a general clinic should be able to manage basic depression if it's not complicated. So if you're in a region where that program is active and there's a designated person, that may be your first point. But the reality is that we have improved significantly, even though we're not where we're supposed to be, as it regards to psychiatric care. Most parishes have got their own psychiatrists with several mental clinics per month, and I think that for some of the complex cases, that's the place to go. Now, there's an issue, and I'll speak about the elephant in the room. There are some patients, because the primary issue is that it's a medical diagnosis. Why are you sending me to a mental clinic where they have the man who has schizophrenia and bipolar disorder? I don't think that that's the place for me. It's a complex issue, because if you decide to have different clinics, are you now engaging in discrimination in providing that kind of structure? So there are some questions about that. You know, at KPH, fortunately, some of the cases that you send to me, they don't have that problem, because, you know, my clinic is located on the neurology side, different from the general psychiatry clinic. So I've never had a patient come and say, why Dr. Tolori send you to me? You know, I don't have that question. And I know that the fact that it's not located where the general psychiatry patient would attend adds. But that is something that we have to work with as a group, you know, and answer those questions. Do you have specialized clinic? And do you have the resources, or do you use the existing resources, which may be easier, but then you have the issue to deal with? For example, you know, I'm a lupus patient. Why am I going to the same clinic as someone with schizophrenia? That need to be worked out. Yeah, right. So, psychologists and social work, you know, clearly would be a part of the treatment model, and not just the psychiatrist and the mental nurse. But the reality is that in terms of availability, we don't have as many psychologists and social workers available in the government system, which is why I probably make reference to psychiatric clinic, mental health clinics, you know, because we don't have it. We do have psychologists privately, but then cost may be an issue for some patients.
Thank you, Dr. Roberts. Are there any more questions from the audience? Any questions, comments? Yes, we have the mother of our lupus warrior.
Okay, so it's not really a question, it's just that most persons don't really know about lupus. Well, I can say myself didn't know about it before Siobhan, because like I go somewhere with this band, they'll say, our pin, they'll say, is that breast cancer? I said, no, it's lupus. And they're like, what is lupus? Is it cancerous or anything like that? So is there any way that it can be out there more, where persons can be more aware about lupus?
Okay. Dr. Roberts, you want to take that question?
Yeah, you know, this is one case where social media can be very helpful. You know, I'm a part of an organization, Bellevue Hospital, that has an active social media presence, and it does transform how people view the work that you're doing, and how information is disseminated. And I think that is about having people in spaces. You have so many platforms, and a lot of, especially younger people, everybody, or most of them, would be Facebook, Twitter, Instagram, something of that sort. And it's about having information being disseminated in various ways. And as I said before, it's about reaching people in spaces that they congregate, like churches or schools and so forth.
Definitely, to take your point on, you know, spaces, church, school, but when you think about the work that the Lupus Foundation does and their own social media pages, which are pretty active, there still seems to be a gap is it that we just need, more strategic social media management that we don't know how to do? I'm not sure because,
Well,
there's a presence. So
yeah.
take your social media presence. Is it that you post regularly all the time? You have people reposting?
Well, I'm
what would you
a bit of
attribute
an
the
old school
success
guy.
to?
I'm a bit
Yeah,
of an
me
old school,
too,
right? So I'm not
that's
too
why
much
I'm
social
asking.
media. But what I would say, if you want to have an impact in terms of social media,
Yeah.
then they call them social media influencers. You have to get people that have the following and try to partner with them.
Gotcha.
So it's a strategist to it.
Yeah. Dr. Jarrett wants to make a comment on that.
So I was gonna, before you said that, so the Bellevue Twitter, whoever your social media manager is, connect. They're witty, current, whatever is trending, they have a way to bring it back to Bellevue. So I follow Bellevue and they're engaging. So you need the right person managing your social media with an eye to sort of have an impact in that way. But I know for us, some of the programs that we've wanted to roll out, working with influencers have been critical. So there are influencers who have programs so you have that sense of the audience you need to reach. And you find that influencer who connects with your demographic and you work with them. So for example, in a rolling out PrEP, which is pre-exposure prophylaxis for HIV, we wanted to get to young people, but we wanted to not just tell them about them, but have them ask questions about it. And so I'm not promoting, I'm just sharing. So Kareem Boyatings was a good person to work with because his program, it's on radio, he also has a social media presence, and it's engaging where you're asking questions and getting answers, and you can have your doctor on with him, you can have your peer outreach person on with him, and have a whole conversation, and then that conversation continues online for like 2-3 days after the program. Right, so very strategic, find the right influencers, because certain influencers aren't convincing and won't connect and really get your message across in a way with impact. So influencers are part of the social media landscape now if you want to have that viral moment or you want to really reach your audience.
Okay, thank you so much. Thank you. We have a question here from Mr. Steinsker. Kevin.
Good afternoon. Well, thank you
One
very
of
much
our
for having me.
sponsors, representing one of our sponsors.
Well, thank you very much. I had a quick question because I'm also a pharmacist and I was listening to the presentation about research and prevalence, and I'm wondering if any research was done in terms of oral contraceptives possibly precipitating lupus, or also, well, I know about exacerbating it and we have to have caution with like high dose estrogen contraceptives, but what about in terms of all of the patients that we've had, have all of them been on oral contraceptives? Just throwing it out there because I know 2 persons personally that have lupus and were on high dose contraceptives, and I don't know if there's a correlation, so just wanted some clarity.
Okay, so our panelists probably can't speak to that, but I think the point that you're raising is important in that there is an association with high estrogen content, contraceptives, and perhaps, so certainly there are guidelines that tell us how to treat, what contraceptives to use in our patient population, and it's not just one size fits all. It depends on whether it's lupus that is controlled or lupus that is very active, whether it's lupus with antiphospholipid syndrome or not. So definitely the education needs to be there for patients living with lupus, that they should know that it is an issue, because people kind of think of contraception as something benign. I'm on the pill, I take a pill, everybody takes a pill. But what we have to, and we do so with our patients from the very moment we meet them, we ask about contraception, we ask that important question, do you plan to be pregnant in the next 1 year? And that leads you to that contraception question. To the wider population, it being a risk factor by itself necessarily speak to that where everyone should have a discussion per se who doesn't have lupus or isn't being evaluated for lupus to have that question. But certainly what it speaks to is the need to know about that association on a general level and certainly in the lupus community. Does that answer the question?
Well, can I just, I know I've asked too many questions, but I just have one more, or just a comment. Actually, a comment, because we were talking about, the mic's on, I'm sorry. Sorry, just a brief comment, because we were talking about policy, that's one thing, and just picking up on a couple of things that all our panelists said. You know, we are missing the social worker who should have been on this, this panel, because he was going to speak from an experience of being an experienced medical social worker, working with programs similar to the ones you spoke to, but also having been one of our board members on the Lupus Foundation responsible for services and the kind of assistance that we try to give patients through the Lupus Foundation of Jamaica. And we found out that when people approached us for medical expense, that there were always other things that needed to be addressed, and it wasn't always about the money. So sometimes it's about, as our panelists said, finding the resources or getting the help and so on logistically. And so we found that we would always meet to discuss each case, a health professional and as well as, you know, the social worker or whoever got the story from the patient to decide what to do. And that was a very helpful approach for the patient and usually worked out a lot better than just throwing cash to the problem. But what it talks about is the social determinants of health include things that we don't all have control over. And that's partly, I think, where policy comes in, because apart from healthcare access, which is something that we're always advocating for, I was looking at the little ski bata here, and it says healthcare access and quality, education access and quality, economic stability, social and community context, neighborhood and built environment. There's so many things that are even outside of the Ministry of Health. And so it's really helpful from a policy standpoint to know that. And I just want to connect this with research. Sometimes there can be a cycle, because we all know that many times what drives capacity and opportunity to do research is what money's out there, okay? So we know that somebody at a ministry or somebody in an institution says, oh, there's money out there for this, therefore we will go for that, okay? And sometimes we're in a cycle where there are some areas that are heavily resourced, and then as you do more, you get more data at the same time. So a lot of intervention things actually are the means by which data is being gathered. And sometimes you have to find other ways to break out of that cycle. And fortunately, this is a role for advocacy. And this week, we actually had the privilege, a delegation of us from Lupus Foundation of Jamaica, met with the Prime Minister this week. And it was partly just acknowledging the kind of support that has allowed us to function. Several of us work in the public sector, and we have access to the mycophenolate that people in other countries, including Canada, are struggling to get, and so on. Mm-hmm. We have access to different things, and there are now rheumatologists in the public sector that patients have access to. This matter of the Prime Minister shared his account of how he ended up advocating or approaching the Ministry of Health himself to get lupus on the list of conditions covered by the NHF, and it was an encounter on the plane with a patient. So advocacy can come in different forms, and we've found that patients are the most powerful advocates, and we are facilitators. And I just want to say that when we talk about the word collaborative, I know you'll sum up shortly, but it's been just a tremendous blessing to have been able to work with Charlene and people like our board member, Vivian Harding, and other people are in these other disciplines who have actually helped us to find a way to, approach a problem and break the ice on getting the kind of information that we need to do more and to advocate more. So we're looking forward to that. We're looking forward to being able to engage people in this study, in this needs assessment, and also in the peer support program when it comes on stream, hopefully at the beginning of the year. And we also look forward to people being involved in a patient-led registry that we are also starting next year, and that will open up even more opportunities, including opportunities to participate in clinical trials. And so, you know, we can't just be stuck in a cycle, and, you know, it all starts with conversations. We had in our lupus clinic a joint clinic with the kidney doctors, and it started with conversations like this. And so we hope that one day we will be able to have a joint clinic, not every week, but periodically with our psychologists or psychiatrists and so on. I think we can make it happen, and I think we're finding that there is synergy and there are ways that we can collaborate. And I think, as I said, advocating that you need a social worker in our clinics, unless we say that we need it, then the resource will be found, right? So we can't always wait for the proof, but sometimes there are different ways to advocate that have to bypass the data, and then we can get the data and do more.
I'm going to use that as the summary wrap-up. You know, it starts with conversations. As Dr. Tollereed said, conversations lead to collaborations. And I'm hearing the word connections. It's all the C's, right? You know, connecting pathways of care, pathways that lead to the information gathering that you need, research to develop policies, and connections with people. People connections, peer connections. So I want to thank you so much for your time, your energy, your expertise, your openness, your willingness to share. Congratulations on the work that you're doing in the lupus world. We are all very grateful to you, and no doubt our patients are very grateful. And we just want to give our panelists a round of applause and thank them for their efforts. Siobhan. Oh, nobody taking pictures. You get a hug too. Oh, you got yours already. Sorry. Yeah. No doubling up. Thank you. Mr. Arnold, we welcome you back to the podium to close.
Thank you so much, Dr. McGee and panelists. Very well. I think we have a new social media czar. And Dr. McGee, you're getting a facelift at Cornwall Regional, right? Yeah. Hospital? Right, yes. And the next one is KPH and Bellevue, right? All right, well, thank you so much again. It has been a wonderful, engaging day, and I wish to thank all the speakers and the panelists from this morning, Professor Nigel Harris, Dr. DeCoola, Dr. Tollereed, Dr. Stacey Davis, we had. And, well, we have the current ones here. So that's Dr. Roberts and Charlene Jarrett and Siobhan. I want to thank you so much. And those earlier, Dr. McLeod, earlier on. And I would like to thank the executive of the Lupus Board and the volunteers, and also our audio-video persons, our sponsors, Platinum National Health Fund, Indus Life Sciences Limited, Wisynco, Stein Cares, Grace Food, Collaborative Care, Rheumatology Solution, Island Grill, CNS, Massey, Mocha Island, and also to our vendors and suppliers, well, the photography and video services, CNS, the tables, chairs, drinks, AV, Uwi Regional Headquarters, the PA system, and the tablecloths, Avantgarde, Harwich, to the Pete Smith and the IT crew, the persons on Zoom. We want to thank you. I know there were some issues, but we're very grateful that you have stayed on. I know there's a storm brewing, so we're not going to keep you back too much. And again, thank you. Same time next year. God bless. Walk good. So, Doctor. All right. Great.
Yeah, man.
Dr. Jared.
Yes.
Good, very.
Which warrior is that?
Yeah. Then you was I am appoint you. Putting you on CBM. Eh? Seriously, I went call CBM and tell them.
Yes.
When I talked to him, I said, but she was funny. And then when I looked at the thing, I said, but she had all US trainings. So it's not
One quick announcement. If you see a pair of glasses anyway, please, could you give it to me? Thank you. Black frame glasses. Okay. No, I just set it here earlier on. You know, moving around. I don't know. Yeah. There's clear one out here. So I thought yeah, take a picture by Come, Diane.